let's look at these more closely. All of the cancers associated with leisure time physical activity are the ones associated either with tobacco use or obesity, and these are the two biggest risk factors for cancer. So this, I made this slide. The paper we're talking about was published 2016. I reviewed this paper and other aspects of physical activity in 2018. But what I noticed is that there are 17 cancers where physical activity is associated inversely with, and they're all either obesity related or tobacco related. So the yellow ones are the ones that are tobacco related. And by tobacco related, tobacco is a strong risk factor. So smoking, caused at least about half the cancers or more. So obviously people know about lung cancer. So it would be obviously good for people not to be smoking, but it would be interesting if physical activity protected against cancers associated with smoking. And this is a summary, a meta-analysis. These are different studies that looked at physical activity in lung cancer. And you can see the summary relative risk was 0.83. So the more physically active people had a 17% lower risk of lung cancer. Now, the question is whether this is a causal association. We don't care so much about associations that are not causal. We want physical activity to really protect against lung cancer. But for lung cancer, it's a bit complicated because we know smoking, this arrow means smoking is a direct cause of lung cancer. We also know that smoking may reduce physical activity, or people who smoke may be less active. And also smoking causes lung disease and loss of lean body mass. So people who smoke a lot may be less active. Now, if that's true, then physical activity may appear to be a risk factor, but it's not really a risk factor in a causal sense. It's just because physically active people smoke more, and it's the smoking that really causes the lung cancer. And that actually is what is actually indicated, because this study this is again a meta-analysis. So these are summary relative risks. So when they look at for recreation physical activity, when they look at the whole population, they see a 14% significant reduction. However, when they stratify by smoking, so among the never smokers, there's no association, it's 0.99, which is not significant. So amongst non-smokers, physical activity is not protective. So we think that's pretty strong indication that it's actually the smoking that's causing the increased risk, and physical activity is not a causal risk factor. That point is summarized here. So for cancers that are strongly associated with smoking, it's unclear if the protective association with leisure time physical activity is causal until there's more definitive evidence. At least I will assume that the association is non-causal, and that those who suffer from the effects of smoking, such as lung damage, may be less likely to exercise. So it's not a causal association. So I'm not going to say much more about smoking. It's still debatable, and some people may argue that it could be a causal association. But I'm going to focus more, I think, which is on this remarkable finding that essentially all of the cancers that showed up in that pooled analysis to be associated with physical activity are also considered obesity-related cancers. By obesity-related cancers, these are the cancers that many organizations assume that there is a causal association between obesity and the cancers. So this is a list of 13 cancers, and these are certified as causal by the many organizations such as IARC, that's the International Association for Cancer Research, and then the W World Cancer Research Fund, and Surgeon Generals. These are all causal associations where you can see that these are relative risks summary from meta-analysis. So many studies. So each one of these is based on like 50 studies. So it's these are hundreds of studies that show obesity. And there are other indications looking at biomarkers that indicate that they are causal associations. So excluding the smoking-related cancers, which we already talked about, the cancers associated with physical inactivity are also mostly associated with obesity. So there's this really correspondence between the cancers where, if obesity is a risk factor, physical activity is going to be protective. Obesity has been a consistent risk factor for many cancers. The magnitude of the association varies. So like for esophageal and endometrial cancer, obesity is a very, very big risk factor. For the others, it's less. Obesity is one of the factors. It's not the only factor, but they all add up. 13 cancers are actually quite important from a public health perspective. Let's think about this a little bit. So if we think of obesity as adiposity, so physical activity may have two effects on cancer. One, there may be a direct effect. So it may have something unrelated to adiposity. It has nothing to do with obesity. But we know physical activity also reduces body fat. So there could be at least two types of mechanisms. One is where physical activity is beneficial because it reduces adiposity, and the other is because it has other effects on cancer. So this is the same study, the Moore study that showed all the cancers associated with physical activity, protective association. These are the hazards ratios or relative risks that are not adjusted for BMI. And so, like, for example, let's look at esophageal adenocarcinoma. Physical activity was associated with a 42% lower risk of cancers of the esophagus. Now, when they adjusted statistically for BMI, body mass index, it was a 38% reduction. So it got a little bit weaker, but it's still there. So most of the effect appeared to be from physical activity and not the BMI. So, and the contrast and example is endometrial cancer, which there was a 21% reduction in risk being physically active, but this essentially went away. It was only a 2% non-significant reduction when you adjust it for BMI. So this doesn't say that physical activity is not important for endometrial cancer. It just says that the effect of physical activity is largely mediated through BMI. So, for example, for esophagus, it's 10%, 90% is directly related to BMI, to physical activity. And for endometrial, physical activity is probably acting largely by reducing adiposity. Most of them are like 70% range, 75, 76, 70. This is kind of a simplifying slide. If we think of it this way, it's physical activity affecting body weight, and then that's being protective for cancer, or other effects of physical activity. Based on the studies that I showed, we'd say roughly, and these are approximate, 2/3 of the effects for most of the cancers, except for endometrial cancer, is the effect directly on cancer, and then 1/3 is by reducing adiposity. So this is essentially what I just said. However, we should look at visceral adiposity, which may be more insightful than just body mass index. I think many are aware that body mass index is a useful but not a perfect indicator of adiposity. And we'll see why this is particularly important for physical activity. So these are two scans, CT scans done at the navel, the umbilicus. So you can look at visceral fat, and the fat shows up white. So this is more fat. This is more like muscle. So as many people know, there are two large components of fat. One is visceral, around the organs, the viscera, and then there's subcutaneous fat. So what's interesting is here, these are two individuals with the same body percent fat, age, sex, and BMI. The BMI is 24. But you can see that there's 3 to 4-fold higher level of visceral fat in this person. And this is also for the same waist. So in other words, you can have two people with the same body mass index, even the same waist, but you can have big differences, 3 to 4-fold differences in visceral fat. And it's particularly important for Asian populations, such as in Korea, where there's a tendency for people that people have lower BMI in general, so their body weight's lower, but they have a tendency to accumulate visceral fat. So this is a similar slide. I put this here sort of for fun because these are 8 different men with the same circumference, and you can kind of see a big difference in almost an 8 to 9-fold difference in visceral fat. That's an incredible difference. And so I had a little quiz here. I look at A and B. One of these is likely to be an athlete, and one of them is a couch potato. And if I was there, I can see you can raise your hands if you think which was more likely to be the athlete and the couch potato. But the main point here is that even with the same body mass index and waist circumference, you can have a big difference in visceral fat. So those are nice pictures, but I wanted to show some actual data. So this is from a meta-analysis. Now, each point here is from a study. So each point is from an intervention study. So these are actual interventions, not just observational data. And so the black is studies of caloric restriction, and the open circles are from exercise. So these are various studies, like some may have been 3 months or 6 months, different interventions. But the point here is, so let's focus on the physical activity, the open circles, is that this is the weight change they had in the study, percent weight change. And this is the percent change in visceral fat. So, for example, you can look at this study. This is one of the extreme studies where in the intervention, they only had about a 2% weight drop, and they had about a 40 to 45% reduction in visceral fat, dramatic reduction in visceral fat. So you can kind of see the slope here. Like overall, there's a 5% weight change corresponds to about a 20 to 25% reduction in visceral fat. But there's some studies that show, these are probably the studies that people were more compliant. So you can actually show like some studies where people had, less than a 10% weight reduction, but a big reduction in visceral fat. Now, I just wanted to show one study might make the point a little easier. So this is a representative study, but remember, this is based on many, many studies. So in this study, this was a 12-week exercise, and it was like 5 days a week for 50 or 60 minutes. These are people that were largely obese. So this is 3 months, not that long. The BMI dropped 3%, hardly dropped, 33 versus to 32 units, hardly a drop. But the visceral fat, which they measured directly, dropped 22%. And then they looked at insulin resistance, and that dropped 35%. So physical activity had a big impact on insulin resistance, which is probably important for cancer, but hardly a drop on body weight. So that's important to keep in mind. So this summarizes that. So moderate levels of physical activity, such as a daily hour brisk walk, may not have a large effect on body mass index, but it will have a substantial effects on visceral and also hepatic. The visceral fat's also strongly associated with liver fat, which also may be important for cancer. And various lines of data are compatible with the effect of physical activity on many cancers is largely mediated through a reduction of visceral and hepatic adiposity, and subsequently on insulin and inflammation. This is a conceptual slide, and I'll go through this because I think it has some important points. And this really, I think, for me, summarizes obesity, physical activity, and cancer. I've been studying this for about 30 years, and I think that this slide summarizes almost everything that I learned, which is kind of sad. But anyway, so let's think of the yellow here is the body's, like the adipose tissue. And roughly 90%, it varies, but 90% is subcutaneous fat, so the fat under the skin. And only 10% is the visceral and a liver fat. So this is a small component. But interestingly, this is the component that's really sensitive to physical activity and also diet, which I won't talk about today, but there's a lot of similar arguments we can make for diet. And I showed you previously, remember just the previous slides where physical activity had a big reduction in visceral fat, but didn't really change overall body fat that much. What's interesting is that the visceral and hepatic adipose is the primary determinant of things like inflammation and insulin resistance. And I think this is what's important for various cancers, particularly the digestive system cancers, which I'll talk about a little more. Now, remember, endometrial cancer, you had to have a reduction in body weight to have the effect of physical activity. So physical activity was only beneficial if it was enough to lower body weight. And the reason is likely that endometrial cancer is not associated with visceral fat. There's other evidence for that. It's the overall fat which produces estrogen in postmenopausal women that's associated with endometrial cancer. So this slide really kind of summarizes the effects physical activity on visceral and hepatic adiposity and the mechanisms that affect mainly digestive system cancers, and then estrogen, which is also important, but it's related to endometrial cancer. Okay, so now for the last part of my talk, I think I hopefully convinced you, if you weren't already convinced, that physical activity does causally lower risk of some cancers. Broad question, I think physical activity is definitely important for cancer. So the remaining questions are largely details, and these are important details, so I put that in quotes. So like how much, what type of activity, when in the life course, how much of a benefit. And then mostly what I talked about is aerobic exercise. There's also weight training that's been less studied. So these are the important practical questions. And I'm just going to show a little data from the 3 studies that I work mainly with, and Dr. Dong-Hoon has also done a lot of these studies. So these are the Harvard cohorts, Nurses Health Studies 1, 2, and Health Professional Studies. And I think that the reason these studies are important, and I'll show, is that they have repeated measures of physical activity every 2 years over a 40-year period. Most studies, epidemiologic studies, have 1 or 2 at most measures of physical activity, but we measured every 2 years over a 40-year period. So we get really person's lifelong physical activity. We have validated physical activity and lots of other data. These are very large studies. I won't have time for much of the details. This is one of the recent questionnaires. These are the different questionnaires we ask, basic activities, most common in the US. And we've been now asking about intensity, and we have weight training questions. So I don't have time to spend on the questionnaire, but I think why these cohorts offer unique data that supports much of what I said, but gives some information on those and like some of the details. So it provides a better dose response for independent effects of vigorous and moderate physical activity. Important question is, do you have to do vigorous activity, or is moderate enough? And it limits reverse causation and tells us when in the life course physical activity is beneficial. So I'll just show some data. Now, some of this is a little bit technical, but I'll try to explain this. This is a study Dr. Dong-Hoon Lee did. This illustrates an important thing. This is a dose response. This is looking at mortality, total mortality, and this is physical activity met hours per week, so going up. And then we did the analysis in 3 different ways. You get 3 different types of dose responses. The first way, we just used one questionnaire, the baseline questionnaire. We didn't update the data. And it does show a reduction with more physical activity, but then actually the risk starts going up. And sometimes people describe this U-shaped association. If you have too much activity, it may be bad. But when we use repeated measures, you see a very different dose response where you get the benefit or the reduction in all-cause mortality, but then it levels off. So maybe getting, once you reach this point, doing more won't help you, but it won't hurt you. So I think that's important. So it shows you a difference in whether you use only one questionnaire like most studies do, or you have repeated measures. And then the other thing is, so you get a better dose response if you have repeated measures. This is another analysis done by Dong Hoon that looked at vigorous activity and moderate activity. This is the reference group are people that do neither. They don't do much vigorous or much. And then these are categories of moderate physical activity. So you actually see pretty high levels, 300 to 559 minutes per week. And what you kind of see here is that you can do either moderate or vigorous, and at some level, you max out the benefit. So, for example, if you look at people who do very little moderate activity, they do mostly vigorous. And the vigorous is here, so this is going up in vigorous. So this is 300 minutes per week of vigorous. So there's a 40% reduction. So if you do very little moderate, you can get up to a 40% reduction if you do a lot of vigorous. And likewise, in this case, if you're doing 300 to 599 minutes of moderate, so you do a lot of moderate acts, you walk like 2 hours a day, you can do vigorous activity. It doesn't hurt, but it doesn't help you. So you kind of max out the benefits. So this addresses the question, again, for all-cause mortality, is you need to do, you can do both, or you can do a combination, but you don't have to do vigorous. You can get the benefit by doing a lot of moderate activity. Or if you don't have time to do moderate, to walk, you could just do more vigorous activity. So now getting back to cancer, I mentioned that a lot of the benefits for cancers were on the digestive system. And this is not our data, but this is from a meta-analysis from 47 studies. And you can see all throughout the GI tract, you see reductions, or at least associations, where high versus low physical activity shows a reduction. But this doesn't inform on the dose response. So we actually looked at this, again, using the repeated measures. This is a study done by, led by Nana Kyung in 2016. And these are for the whole digestive system. So all of these cancers combined. So a lot of cancers. And what you can see here is the dose response. So up to a degree, more is better. And the maximum benefit was at about 30 met hours per week. So that's about, roughly, if you do it all in walking, about 450 minutes of walking, or running 225 minutes a week, which is actually, a bit more than the recommendations. These are the minimum recommendations, which would be like, let's say 150 minutes of moderate activity. You do get a lot of benefit, but you actually get more until you reach about 450 minutes a week of walking, or running 225 minutes a week. Now, timing throughout the life course, I'll just focus on this one. So this is colorectal adenoma, which is a precursor for colon cancer. So this is kind of like studying colorectal cancer at an earlier stage. And in this study, so the reference group is the low physical activity in adolescence and low physical activity in adulthood. So relative to these people, you get a big benefit if you're highly active in adolescence and in adulthood. You have about a 40% lower risk. But you do also get some reduction if you're high in adolescence and low in adulthood. So it does show that you do get, at least for colorectal cancer, you do get some benefit for being active in adolescence, which is nice to know. But if you maintain the activity, you get even a bigger reduction. But this helps inform on the life course, like when is physical activity important. It's important both early and late for colon cancer. Now, for pancreatic cancer, it's kind of interesting that in that study that I showed, it was actually one of the cancers, that did not have a significant reduction. It suggests a 5%, but not a significant reduction in risk. Now, what's kind of interesting is that we've done some studies led by Chen Yuan that looked at pancreatic cancer and actually show really strong, these are other risk factors like obesity and smoking, not for necessarily for physical activity, but risk factors for pancreatic cancer are very strong for those under 60, and then get weaker for those 60 to 70, and then almost don't exist for those over 70. So in other words, pancreatic cancer seems to be more preventable at younger ages. When you get to older age groups, it gets less protective. So we went back and looked at physical activity by age. And we did see that in the younger age group, under 70, being inactive was associated with a 37% increased risk, but there was no benefit for older age. It's not to say that older people shouldn't be active, but for pancreatic cancer, most of the benefit will happen early in life. And then finally, for prostate cancer, remember I talked a little bit about a slight increased risk in total prostate cancer. However, we've seen that prostate cancer has the opposite. Remember, pancreas, its early life is important. For prostate, it's later life that's important. And it's vigorous activity at high levels and for advanced prostate cancer. So it's very specific. It's the associations can be different by cancer. So for prostate cancer, to get a benefit, it's mainly in older men, and it's only for vigorous activity, and it's for pretty high levels. There's not a linear dose response. So we don't know exactly why that is, but there may be something peculiar for prostate cancer. So just to summarize, maximal benefit and overall cancer would occur for maintaining physical activity over the life course, but for specific cancers, there could be periods of special importance. So for colon, it may be early, midlife for pancreatic, and late life for prostate cancer. And so just to finish up quickly here, I didn't say much about weight training and cancer prevention. There's very little data. There's a lot of epidemiologic data on aerobic exercise. In the health professionals, surprisingly, for colon cancer, there was an increased risk, but just p-value 0.05 for resistance training, which is a little bit worrisome. And then for bladder cancer, there was a protective association, and for kidney cancer, a suggestive protective association. Now, really, there's only one other study, epidemiologic study. It's called the NIH-ARP, which looked at resistance training in this detail. And it's interesting, for colon cancer, they got the opposite. So it's 0.78, and it was a p-value 0.05. So I think these are just chance findings. So it actually was reassuring for us that another study got almost the opposite. If you combine them, you probably get no association, but that's better than a positive association. For bladder cancer, we had seen a protective association, and they had seen nothing. So maybe our initial finding was chance. And for kidney cancer, it was the only cancer where both studies suggested an association, a protective. So there's a lot less data for resistance training, but at least there's some suggestion for kidney cancer. And I think I need to be closing up here. So these are my conclusions. So leisure time aerobic physical activity is associated with lower risk of 12 cancer types, and associations are particularly strong for digestive system cancer. Now, both vigorous and moderate physical activity are effective. And so recommendations of 150 to 300 minutes per week of moderate, or 75 to 150 minutes per week of vigorous, will lower risk. So the current recommendations lower risk, but I think maximal benefits may occur at even higher levels. Now, the maximal benefits accrue over maintaining physical activity over the life course, but it's never too late to start. You'll get some benefit even if you start late in life. The primary benefits are associated with reductions in visceral and hepatic adiposity and things like inflammation and hyperinsulinemia. And the benefit can accrue even with modest weight reductions. You don't have to lose a lot of body weight to get the benefit. And on weight training, the evidence is limited, and there's some suggestion for a benefit on kidney cancer, but more work needs to be done for weight training. So thank you, and I'd be happy to take questions at this point. Thank you so much for the invitation. It's a pleasure. I
because you are heavily involved in the WCRF group, so I just want to hear your thoughts why there are some differences.
Yeah, that's a great question, and I think the difference has to do just with the timing of the recommendations. I was actually on the panel for the WCRF, and we hadn't updated the evidence of all like the human evidence up to about like 217, the year 2017, and so at that time, like for example, we couldn't evaluate. We were doing like periodically, like let's say 2014, 2015, we did different cancers. And so we really didn't have that large study by Moore, the one that I spent some time showing, that hadn't been published yet. So of course, I can't speak for certain, but I suspect strongly if we had that study, based on the criteria that we use for assessing associations, that we probably would have considered a lot of those other cancers, maybe all of them. We'd look, one by cancer. So I think it had to do more with the timing, and I suspect in the future that the WCRF does update periodically. So hopefully I will certainly recommend for them that they should really update their physical activity, because I think it's very much of an underestimate of the benefits of physical activity on cancer. So I think that's the main reason. But and I think based on their criteria, which I know very well, if they reviewed the current evidence to date, that they probably would come up with many more cancers associated with activity.
My question is that, in your presentation, you said physical activity is more beneficial in people with, for the digestive cancer. Why do you think is that?
I'll give two answers. One of them is maybe not that, maybe it's a trivial type answer, but the visceral fat does cover it's the viscera covers the digestive system. And also we don't consider the kidney the digestive system, but the kidney is also embedded in the viscera, which is interesting. So there could be a direct effect. So maybe the proximity of the fat and like things like inflammation, it might be more strongly just linked by the circulation to the digestive system. Another thought that I've had, and this is really not proven, but the things like insulin, for example. So we think like, why should insulin be related to cancer? Now, low levels of insulin suggest that you're like sort of low energy intake, or low, like when you're eating a lot, and, if you're eating all the time and high fat, high carbohydrates foods, you'll have high insulin levels. So that may be a signal that there's a lot going on, like there's a lot of energy intake, the energy balance is positive, so your digestive system is active. So maybe insulin is a signal for the digestive system to be active. And there are studies that have shown that lowering insulin reduces cell proliferation, at least in the colon. I don't know about the other digestive system. Mm-hmm. So it may just be that, like, if you're physically active or eating less, you want to like down-regulate the activity of the digestive system. Why should you waste energy on your digestive system if your energy balance is kind of negative? So it may, and the whole digestive system maybe, has this commonality in like the time, like when it should be active, when it shouldn't be active. So that's more of a speculation, but it does tend to tie why something like insulin, which signifies energy balance, would be tied specifically to digestive cancers.
Thank you so much.
Thank you.
Thank you. Thank you.
All right.
Enjoy the rest of the symposium.
The wonderful lecture and the smart conversation. And we'll take that. Let's go to the next topic. Let me introduce the second speaker, Professor Dong-Hoon Lee. He is the assistant professor in Department of Sport Industry Studies, Yonsei University and Republic of Korea. He has performed many excellent researches in the field of physical activity, epidemiology, nutrition, and big data science. Please give up, Professor.
Thank you for the introduction and for this opportunity to present at the Yonsei Exercise Oncology Symposium. Following up on Dr. Giovannucci's insightful talk on physical activity and cancer prevention, now I want to switch gears to talk more about physical activity and cancer survival and show some epidemiological evidence from large cohort studies. In this presentation, I will start by briefly overviewing the burden of cancer and the current epidemiological evidence on physical activity and cancer survival. And lastly, I will end by providing how epidemiological studies can enhance precision exercise oncology. Probably not a surprise for this audience, but cancer is a huge problem with more than 80 million new cases globally. The lifetime risk of cancer in the US is about 40% for men and women. So there is more than 1 in every 3 adults. And we can see a similar trend in South Korea and many other countries. At the same time, cancer survival has doubled since 1970s. And now 69% of cancer patients survive for 5 or more years. But the survival still largely varies by cancer types and stages, ranging from about % to over 90%. If you look at the figure on the right side, the number of cancer survival is projected to increase by 40% from now to 2040. In terms of cancer types, a large number of cancer survivals were diagnosed with breast, prostate, or colorectal cancers, followed by combined gynecology and hematology cancers. So not surprisingly, majority of epidemiological studies have focused on these type of cancers. It is estimated approximately 1/3 of deaths are attributable to modifiable factors like excess body weight, diet, and lack of exercise. So we know that a large number of cases can be prevented by increasing physical activity and also by maintaining a healthy weight throughout life. But what about cancer survival? Unlike cancer prevention studies, much less is known for cancer survival. And more survival studies are needed because etiological factors for cancer developments are not necessarily the same as those for cancer survival. As exemplified in this table from WCRF, summarizing the evidence for breast cancer development versus breast cancer survivorship, there are differences in risk and protective factors associated with the two, and also limited evidence exists for cancer survival. Just like in understanding of complex etiology of cancers, 4 studies are crucial in epidemiological research. As you can see in this map of existing cancer cohorts, many of them are located in North America and Europe, and a limited number exists in Asian countries. Today, I will show epidemiological evidence on physical activity and cancer survival generated from some of these well-established cohorts listed here. Okay, so first is on physical activity and breast cancer survival. Because of large number of breast cancer survival, breast cancer is actually one of the most actively studied cancers in relation to physical activity. One of the first studies that examined the role of physical activity after breast cancer diagnosis on survival was published in 2005. This study included about 3,000 women diagnosed with breast cancer in the Yonsei Cell study in the US and compare the survivals by physical activity. In this figure, on the left side, we can clearly see that breast cancer patients who had more than 9 man-hours per week of physical activity had lower mortality compared to those who had less than 3 man-hours per week of physical activity. In multivariable adjusted model on the right side, high physical activity was associated with about 40 to 50% decreased risk of total death, breast cancer deaths, and recurrence. With the maximal benefit shown around for people with 9 to 15 man-hours per week of physical activity. This is equivalent to about 3 to 5 hours per week of walking. After this study, a number of studies have been published, and in 2019, a meta-analysis of 8 prospective core studies showed consistent result that higher recreational physical activity after breast cancer diagnosis is associated with about 40% lower all-cause and breast cancer mortality. Although physical activity has been consistently associated with breast cancer mortality, one important limitation of existing literature is that most studies used physical activity data at one time point. To address this limitation, a recent core study from Delta P study, they collected physical activity at 4 time points, before diagnosis, and during treatment, and after 1 and 2 years of follow-up. And as you can expect, there was a decrease in physical activity during chemotherapy with 54% of regular physical activity, in contrast to before diagnosis at 73%. And the highest prevalence was shown after 2 years of follow-up, which was 75%. In the same study, they used time-dependent multivariable risk models accounting for activity from all time points, and found that lower volume of regular physical activity were associated with similar overall survival advantages as meeting and exceeding the guidelines. For example, patients who had any regular physical activity showed about 62% lower all-cause mortality, which was similar to those who met the physical activity guideline. This is particularly encouraging for patients in survival who may be overwhelmed with the current physical activity guideline recommending more than 150 minutes per week of physical activity. Okay, next for colorectal cancer survival, similar results were found. One of the first study was published in 2006, and this study included about 600 women diagnosed with colorectal cancer from the Yonsei Cell study that I mentioned earlier. Compared to the breast cancer study, which shows significant association for those who had more than 9 man-hours per week of physical activity, here we can see that colorectal cancer patients needed more physical activity level above 18 man-hours per week of physical activity to achieve 50% decreased mortality. This is equivalent to 6 hours per week of walking or 4 hours per week of moderate physical activity. For those who had both pre-diagnosis and post-diagnosis measurements, they calculated change in physical activity and examined the association with survival. Compared to those who did not change their physical activity, those who increased their activity showed about 50% lower colorectal cancer specific and overall mortality. In contrast, those who decreased their activity showed non-significant increase in mortality. After this study, more studies have been published, and a meta-analysis of 6 core studies showed similar result that higher physical activity before and after colorectal cancer diagnosis is associated with reduced overall mortality. Okay, next is on prostate cancer, which is the most commonly diagnosed cancer in men. The evidence on physical activity and prostate cancer survival is relatively new compared to breast and colorectal cancers. I just want to introduce one paper published in 2011 using the health professional follow-up study. This study included 2,700 men diagnosed with prostate cancer, and found that men who had more than 9 meta-hour per week of physical activity had about 30 to 60% decreased risk of total death and prostate cancer deaths. When they examined the association by physical activity intensity, both non-vigorous and vigorous activity were associated with lower all-cause mortality. And lastly, because the walking comprised 36% of total man hours per week, this study further investigated the association by walking duration and pace. The yellow bars here indicate slower walking pace, and blue bars indicates a faster walking pace. So as a result, men who walk more than 90 minutes per week at a faster pace had about 46% decrease all-cause mortality compared to those who walk for a shorter duration at a slower walking pace. Similar but non-significant results were found for prostate cancer mortality. So overall, there were consistent results that post-diagnosis physical activity is associated with lower cancer-specific mortality and cancer recurrence. But notice here that there are only like 3 cohort studies included in this meta-analysis, so there is need to study more on the relationship between physical activity and prostate cancer survival. Based on the current epidemiological evidence, including the ones that I presented today, 2018 Physical Activity Guideline Advisory Committee concluded that there are moderate evidence that physical activity after diagnosis is associated with lower, about 40 to 50% lower mortality for breast and colorectal cancers. But the evidence for prostate cancer is a bit more limited. It is also worth noting that compared to cancer survival studies, there are stronger evidence that physical activity reduces many types of cancer risk, including breast and colon cancers. So this suggests that there are still large discrepancies in epidemiological evidence for cancer prevention versus cancer survival. Okay, so that's where we are for breast, colorectal, and prostate cancer survival. And for the next few slides, I want to briefly talk about the role of physical activity on other cancer survival. Endometrial cancer is the 6th most commonly diagnosed cancer in women, but there are only a couple of cohorts that examine the relationship between physical activity and endometrial cancer survival. In a Canadian cohort of 425 women diagnosed with invasive endometrial cancer, higher total physical activity, especially recreational physical activity, were associated with 55 to 67% decreased risk of total deaths and endometrial cancer deaths. However, occupational and household activities showed almost no association. And moreover, when looking at the changes in physical activity in relation to survival, a patient who maintained high physical activity at all times had improved disease-free survival and overall survival compared to those who had low physical activity at all times. But just like endometrial cancer, evidence on other types of cancers are all lacking. As you can see in this first plot from a recent meta-analysis on post-diagnosis physical activity and different types of cancer survival, there are only a couple of cohorts for cancers like childhood, esophagus, kidney, lung cancer, stomach cancer, and so on. So more studies are needed to support the benefit of physical activity for survival of these different types of cancer. Okay, so another important way forward for exercise oncology is to embrace precision medicine. Precision medicine is an emerging area in oncology that attempts to address the substantial variability in individual patient response to cancer therapy. The aim is to give an intervention to patients who will benefit more than the others. For the remaining time, I want to share some ideas how epidemiological studies can inform precision exercise research. First, observational studies relating biological mechanisms to cancer outcomes can help demonstrate clinical relevance. Prospective or case control studies of cancer patients can complement preclinical research in clarifying the biological mechanisms influencing cancer survival. And second, core studies are helpful, but we need more randomized controlled trials to demonstrate the effect of exercise on cancer survival biomarkers, such as insulin, IGF-1, and so on. It is important because exercise trials can provide stronger evidence of causality, and it also allows us to compare different types, frequencies, durations, and timing of exercise on cancer biomarkers, which can help us define more precise exercise prescription for individual patient. And third, evidence of biomarker RCTs should be complemented with our prior knowledge on exercise biological mechanisms underlying cancer survival. Biomarker RCTs are helpful to establish causal effect of exercise on specific biomarkers, but they cannot be directly translated into cancer survival benefits. And this is particularly true for newly hypothesized biomarkers or those that are less reliable. So in order for this evidence to be translated into an actual exercise prescription, we need to synthesize our prior knowledge on how exercise reduces body fatness, inflammation, and insulin resistance, for example. And lastly, molecular epidemiology studies can generate compelling hypotheses to guide large-scale trials incorporating precision exercise questions to identify patients who may be responsive to exercise prescription versus who may be resistant. And also, such a study can support a causality with respect to the hypothesized biological mechanisms. For example, molecular epidemiology studies of colorectal cancer patients from Nurses' Health Study and Health Professional Follow-up Study show significant benefit of physical activity for subgroups of colorectal cancer survivals expressing P21, P27, COX-2 positive, and so on. Therefore, compared to conventional epidemiological studies, which shows how physical activity improves cancer survival on average, molecular epidemiology studies allow us to incorporate cancer subtypes defined by genetic alteration, epigenetic alteration, even response in tumor, and so on, to better understand the etiologic heterogeneity in cancers. So, in summary of my presentation, current epidemiological evidence shows that physical activity before and after diagnosis is associated with a lower mortality in patients with breast, colorectal, and prostate cancers. Although limited, there are suggestive evidence supporting the benefit of physical activity for other types of cancers. And molecular epidemiology studies can help us understand the heterogeneity of cancers and guide a precise exercise prescription. And lastly, more epidemiological research is needed for additional cancer sites and also using enhanced methods to advance precision exercise oncology. Thank you very much for your attention.
Thank you, Professor Lee, for the excellent lecture and the clinical meeting. We will take the questions or comments for all the topics together as part of the panel discussion. That's the third topic. And from now on, I'd like to hand over the moderation to my co-chairperson, Professor Lee.
Thank you. I introduce the lecture. The lecture will be given by Professor Jiyoung Choi. Jiyoung Choi will give the lecture on the topic of examining physical activity profiles and their impact on cancer risk and prognosis, insights from the Health Examination Study in Korea. She is a professor at the Department of Biomedical Science, Sloan National University Graduate School. Her main research areas are epidemiology, behavior, medication, susceptibility, and prevention. Please begin with us.
Thank you for introducing. I'm very pleased to have a chance to share our study results conducted in Korea in the academic session of sports oncology. I have no conflict of interest. So this is the outline of my talk. First of all, my study is conducted in health examination cohorts. One of the studies of causes conducted by KCDC. So I will introduce HEXA cohort, including HEXA physical activity questionnaire validation. Then I will talk about the associations of physical activity and cancers and the prognosis. So health examination study. This is started in 2004, and we recruited we recruited more than 170,000 by 2013, aged 40 to 69 years old age. We have more than 1,300 questionnaires, clinical and physical examination items. Also, we have a biobanking. Here, the number of instance cases and selected disease. This is the items of HEXA physical activity questionnaire during the period, during the recruit period. There are several versions. In the yellow cell, the very simple regular exercise and the household, which are very consistent during the whole period. And there are several domains of physical activity. There's time, transport, a little bit occupation. So we would like to validate this physical activity questionnaire on HEXA. So we have 3 stages of design. In the pilot study, we selected objective 2 to compare the questionnaire, and the second, we define the cutoff value by intensity versus indirometric calorimeter, the criteria research, and then we assess the reliability and validation of the HEXA questionnaire. So we used several cutoff formula, and then the active graph and ambient were used as field tool, and indirect calorimetry was used as a criteria tool, and then there are several intensity in the treadmill and also pre-living condition. So finally, we used the Troino 2008 formula. And then this is the validation study. We measured 2 times in spring and fall the physical activity, questionnaire, and active and then also lifelong. So this is the reliability of our questionnaire and also so the HEXA PHU has a general reliability. In the repeated measurement in the same person. And this is the correlation between objectively measured physical activity and also questionnaire. And these results also show some general accepted correlation, validation levels compared to the previously reports were used questionnaire validation. So now I will talk about the physical activity and cancers. This is the published in Cancer Prevention Research. As presented by Dr. Silvanji, physical activity decreased risk of cancer, especially in colon and breast cancer. However, most of the existing evidence is based on studies conducted in Western countries. This is the summary from the umbrella reviews of studies from Asia, and the number of studies is not so big, and also the evidence grade is weak. So we would like to evaluate the associations of various characteristics of physical activity with the incidence of total and type-specific cancers in the Korean population. Also, we assess that association certified by obesity status. This is the study population. The baseline has, in baseline, we have 170 population in cancer, but after excluding like age and also some kind of cultural condition, we have we started the Hexa Jan. It's 114,000, and then after linking of cancer registry, finally we have 100 child participants at baseline. This is the exposure and outcome. Of course, the exposure is real-time physical activity. We have several characteristics of physical activity: participation, duration, intensity, types, and diversity. For the category of types of real-time physical activity, we categorize that here: walking, climbing, aerobic, recreation, team-based sports, and strength. And the outcome is cancer incidence overall and type-specific, the main 5 cancers in many of them respectively. So we can get information by linking with Korean Central Cancer Registry, and also we have that certification data from Statistics Korea for sensory treatment. In the statistical analysis, we use post-proportion measurement, of course, and AG is used as a time scale. We assess several models, including known or statistically related confounders, and also certified by obesity status. This is the basic characteristics of our population, men and women. Smoking will increase the risk of the cancer, and among men, and education level, it increase the risk among women. And obesity increase the risk. Obesity level increase the risk. Cancer, men and women. And this is the main result. Real-time physical activity increase the total cancer risk in crude model. However, in men, they are all attenuated after adulthood with full cell confounders. In women, generally they have no significant associations, but in the types, the very small significant one, the recreation types of real-time physical activity increase the risk, but this association will disappear after excluding thyroid cancer in women. After stratified by obesity, the physical activity, real-time physical activity, all types, all kind of characteristics decrease the risk of total cancer among obese men. However, in the woman, there's still some kind of associations about recreation types of physical activity among women. In the type-specific cancer, certified by obesity, actually this result shown by BMI level, but we also tested waist circumference, and the result was very similar. In the colorectal cancer physical activity, real-time physical activity, especially vigorous physical activity, decrease the risk independent of obesity. And in women, the physical activity increased the risk among gastric cancer unexpectedly. So the limitation, the physical activity information that was gathered by the self-reported questionnaire, so there should be recall bias. And there should be potential for remaining covariates. For example, H. pylori infection. We do not have that information. So we thought it's kind of one of the reasons there are some unexpected associations of the gastric cancer in the woman, but we don't know. Also, it is impossible to consider whether obese group achieve sufficient weight loss to prevent cancer through education, through respective physical activity, although we have some significant association among obese men. In conclusion, total physical activity was not associated with total cancer incidence in both men and women. However, physical activity of sufficient duration and intensity can successfully reduce cancer risk in obese men. This is the third topic, physical activity and cancer prognosis in Korea, which is published in Cancer Medicine. So then, in cancer mortality in Korea, the mortality rate slightly decreased. However, the number of deaths for cancer patients slightly increased. So, as presented by the physical activity is proposed as advanced treatment that improves the prognosis of cancer survivors. With this good reason. However, there are limitations in establishing the guidelines by using the results from previous studies. There are limited evidence to compare the effects of physical activity at pre- and post-diagnosis in the same study. And also, we need to consider the characteristics of physical activity, duration, intensity types, and diversity, like personalized physical activity guidelines. So we assess the characteristics of physical activity that can effectively improve the prognosis of cancer patients according to the physical activity before and after diagnosis. The same study population, but after linking with Korean Cancer Registry, we have 7,700 cancer patients for the pre-diagnosis physical activity information, and less than half of them, 3,000 cancer patients for the post-diagnosis physical activity. So this is the study design according to pre- and post-diagnosis. Pre- and post-diagnosis of physical activity. For the pre-diagnosis physical activity, we obtain the physical activity information at baseline, and we confirm the cancer incidence, cancer diagnosis, and mortality during the follow-up. For the post-diagnosis physical activity, we obtain the physical activity information at baseline, and we confirm their cancer diagnosis within 10 years before the baseline. So the same exposure physical activity with various characteristics and the outcomes for cause death and cancer specific death. We get the public database. Yeah, Cook's proposal hazard model was used, and we assessed several models, and finally I will show the adjusting all kind of contact, also cell stage. This is the physical activity at pre-diagnosis and mortality. In men and women, there's some significant results. Actually, among men, there are generally all kinds of physical activity associated, decrease the risk of mortality, cancer mortality, all-cause mortality. For women, several, like vigorous and mountain climbing types, decrease the risk. The risk of death. For the physical activity and post-diagnosis, actually there's no association, no significant association in men and women, although there's some decreasing trend in each gender. So we combine them and find something, physical activity participation or vigorous low woman decrease the risk of cancer death. In the limitation, LTK is self-reported, so still for bias, and physical activity other than result time don't may handle unavailable because of the insufficient statistical power, especially possibility for the lack of the number of events for the cost analysis, and also it's very difficult to analyze in each type-specific topic. In conclusion, physical activity and pre-diagnosis is more effective in reducing the risk of death in cancer patients. And also, intensity of physical activity should be considered in cancer patients. This is my final section. For the study, we would like to find general results in Korean, Asian, as well as in the world. Now again, this is the meta-analysis of the association between physical activity and colorectal cancer. Yeah, it's very significantly decreased the risk of colorectal cancer. However, the previous studies were limited and inconsistent among Asian population cohorts. So, actually, this is kind of a review, and there should be different profile or characteristics in East Asian, especially like low physical activity level is low among East Asian, and also high fat mass index is also low. So currently, we expand our study in the Asian Core Consortium. This core consortium, we analyzing the association between physical activity and colorectal cancer risk among 1.5 million. So hopefully, we would like to find some clue to explain the disparity between physical activity as a risk factor. So I would like to thank you, my colleagues, especially my members, my previous members, they all graduated, and 대희관, 애선, 신, Seoul University, 미영님, 국민 University, and also Juan-mi, Women's University, all they my sincere colleagues. And also, I really appreciate the participants in the project call. Thank you.
Thank you for a wonderful lecture. I think it's more meaningful because it is a Korean data result, and it is very special as it also includes analysis the types and diversity of physical activity. 그래서
Sorry, I didn't hear. I didn't listen.
not important. Now, this is Q&A and panel discussion time. Yeah. Feel free to ask. Audience are welcome to ask any questions and or comments.
들리실 것 같은데.
한국말로 이렇게 좀 편한 언어로 해주셔도 될 것 같아요. Feel free to speak Korean or English. Yeah, and before we ask your name and
English is not our mother language, so it's very difficult to speak and hear. But your research is really different from other research, so I really only 그래서 영어로 지금 들으니까 더 혼란스러운 게 여성에게 있어서 굉장히 특이한 사항들이 하이 에듀케이션이 여자들이 더 암에 걸릴 수 있고 또 아까 뭐가 있었지 운동을 했는데도 효과가 더 없고 이런 내용들을 그 썸머리를 한국어로 좀 해주시면 정말 도움이 많이 될 것 같아요.
네, 저희가 그러니까 사실 서머리는 저희가 생각했을 때는 일단은 아직까지는 피지컬 액티비티가 한국인에서 암 위험 감소시킨다, 혹은 프로텍티브하다 이렇게 말하기에는 좀 덜 익은 것 같다. 그렇지만 그래도 파이널리 그러니까 오비스한 남자에서 약간 비만이 있는 남자에서는 콜레스테롤 캔서나 오버럴하게 좀 나온 부분이 좀 그래도 고무적이긴 합니다. 그리고 그런 결과들이 다른 아시아 코호트들 결과들, 케이스 컨트롤 말고요. 코호트에서도 좀 컨시스턴트한 게 잘 안 나오더라고요. 아시아 코호트에서도. 그래서 이거를 저희가 되게 시그니피컨트한 어소시에이션이 있다라고 말하지는 않으려고 생각을 해서 그렇게 써머리 드렸고, 여성의 경우에는 네, 그렇습니다. 근데 지금 일단 그 남성 결과랑 달리 저희가 피지컬 액티비티를 여러 가지 캐릭터리스틱을 많이 봤잖아요. 근데 남자의 경우에는 운동을 한다, 그리고 150분 이상 한다, 비거러스 한다, 뭐 여러 가지 타입들 굉장히 컨시스턴트한데 여자에서는 그러지 않거든요. 네, 말씀하신 대로 여성에서 에듀케이션 레벨 높은 게 증가해. 이게 토탈 캔서거든요. 토탈 캔서라서 그 부분은 조금 어쩌면은 이게 코호트지만 이 코호트 안에서도 셀렉티브하게 사람들이 들어왔을 수 있고 이 코호트 자체. 근데 뭐 그럴 수도 있고 혹은 이 에듀케이션 레벨이 높으면 SS가 높을 거고 그런 체스가 더 많은 것 같아요. 진단 받은 체스. 뭐 그런 쪽으로 저는 생각을 하고 있어요. 또 사실 유방암, 사이로이드 이런 것들은 같은 방향이긴 하거든요. 근데 피지컬 액티비티가 그러면 여성의 캔서를 증가시켜, 특히 스토막 캔서를 증가시켜 노멀 웨이트에서 그렇게 보기에는 굉장히 좀 작은 결과였어요. 한 가지 리크레이션만 그렇게 나온 거고, 리크레이션을 한다라고 리포트하더라도 저희가 12만 명에서 봤지만 굉장히 작은 숫자고 거기에서 또 캔서가 생긴 사람이 또 되게 작은 숫자인 거예요. 그래서 그거를 유리하다고 말할 게 아니라 저는 좀 펄스 파티 이 부분도 좀 더 봐야 되고, 그리고 또 한 가지 스토막 캔서 같은 경우에는 저희 가장 핏폴이 H-파이오리라고 하는 굉장히 잘 알려져 있는 부분을 그 정보가 없습니다. 그래서 그런 식의 어떤 다른 인포메이션들이 좀 더 있어야 되는 것 같고, 그래서 네, 지금 마지막에 말씀드렸다시피 조금 더 전체적으로 좀 더 큰 규모의 아시안 데이터에서 한 번 더 다시 보고 싶고 그런 리스크 파일들도 좀 더 나눠서 보고 싶고 그런 거를 좀 계획하고 있습니다.
아시안 여성들에게 있어서 훨씬 더 골다공증의 유방률이 더 높잖아요. 그러니까 그 이유가 사실은 아시안 여성들이 유럽이나 서구 여성들보다 피지컬 액티비티의 그 수준이 훨씬 낮고, 그리고 뭔가 그런 노출이나 이런 거에 대해서 이렇게 좀 낮기 때문이다 이렇게 좀 여겨지는데, 그것 자체가 어렸을 때부터 운동을 안 하는 그 습관, 그것이 어떻게 하면 정말 아시안 여성들의 암 발생이라고 굉장히 연관이 있지 않을까. 답변은 자기가 피지컬 액티비티를 했다고 하지만 진정 그들이 피지컬 액티비티 강도가 그 정도 수준이었는데 그것도 굉장히 미치스럽거든요.
일단 아시안 여성이 피지컬 액티비티를 안 하냐 하면은 되게 많이 낮지는 않아요. 피지컬 액티비티가 그러니까 세덴터리 레벨 자체가 낮지는 않아요. 그런데 비거러스한 레벨은 낮죠. 근데 그거는 아시안 여성이라서라기보다는 남성하고 비교했을 때 굉장히 낮아요. 그런데 남성에서 어떤 어소시에이션 나오고 저희 계속 앞에서 말씀하셨다시피 비거러스한 인텐시티가 되게 중요한데 저희 코호트에서도 그렇고 다른 것들도 그럴 거고 이 비거러스 인텐시티를 별로 안 합니다. 여성들은. 그러니까는 이게 그냥 운동하냐 이렇게 물어보는 게 아니라 저는 어떤 항목을 하냐고 40개 이상의 항목들을 다 봐서 토탈 것들을 봤는데 여성들은 굉장히 그 비율이 낮거든요. 그러니까 그렇게 인텐시티가 되게 중요한데 그렇지는 않다. 그런데 여성들이 그렇게 움직이지 않느냐? 그렇지는 않아요. 저희가 오늘은 안 보여드렸지만 모탈리티랑 같이 본 게 있었어요. 레셔틀 피지컬 액티비티하고 하우스홀드, 그러니까 가사일 하는 거. 그걸 봤는데 가사일을 저희가 4개 항목을 물어봤거든요. 근데 가사일이라고 하는 거는 인텐시티가 당연히 높지 않죠. 높지 않은데 그 4가지, 남자의 경우에는 가사일을 합니까 안 합니까? 로 나누어가지고 구분을 해서 결과를 볼 수가 있었는데 여자는 아무것도 안 하는 사람은 없어요. 그 중에 3개 이상 하느냐? 2개만 하느냐? 이렇게 나눠볼 수밖에 없는. 그러니까 시간이 없어요. 일단 한국 여성들, 그리고 저희가 보는 사람들이 이제 40대 이상이었잖아요. 뭐 그런 상황들. 근데 말씀하신 대로 그런 골다공증이나 이런 부분들. 근데 또 이게 캔서 인서지가 좀 낮냐? 아니 높으냐? 그렇진 않잖아요. 그러니까 뭐 좀 되게 복잡하지만 캔서 에스더스 자체는 웨스턴에 비해서 저희 우리나라가 되게 높은 편은 아니고 아시아는 높은 편이 아니고 막 이렇고 물론 그게 이제는 뭐 리스크 프로파일도 있고 다른 시스템적인 것들도 있겠죠. 그래서 좀 여러 가지로 봐야 될 것 같습니다.
죄송합니다만 제가 환자분의 입장에서 조금 포인트를 드리면 지금 피지컬 액티비티가 굉장히 중요한 것은 맞습니다만 우리가 이미 알고 있는 굉장히 중요한 리스크들은 같이 생각을 해야 될 거라는 생각이 들고요. 예를 들어 하늘 에듀케이트된 여성분들이 결혼을 좀 이루거나 출산을 멈추는 경우가 많은데 그건 유방암에 있어 굉장히 큰 리스크입니다. 그래서 그런 부분들을 함께 하고 고려를 하시는 게 어떨까 싶고 골다공증 관련해서는 사실 저희한테 굉장히 중요한 팩tor이 마르신 겁니다. 비능한 거거든요. 그래서 오히려 오비시한 분들은 다른 응가 문제가 생겨도 골다공증은 잘 안 생기는데 마른 여성분들은 골다공증이 빨리 생기는 경우가 있어요. 그래서 그것도 꼭 피지컬 액티비티만의 문제가 아니라 동양인들이 서양인들에 비해서 굉장히 하이리 오비자한 점이 좀 적고 전반적으로 약간 날씬한 편이다 보니 그것도 리스크가 되지 않을까 싶습니다.
네, 또 다른 질문 있으면 부탁드립니다.
아마도 그 뒤에서 질문하셨던 도움이 될 수 있는 일이 같기도 한데 선배가는 여러 가지 학교사였다가 피지컬 좀 운동하고 이게 많이 불거졌어요. 그런데 혹시 여성들에게 먹는 경우에 운동에 대해서 어떤 반응이나 적응을 하는 것들이 상당히 프리젠테이션 하나 이런 엔터프라이즈적으로 접근해서 생각을 보면 어떤 차이가 있나 그거를 하게 되는 거예요. 그리고 이동
굉장히 어려운 질문을 주셔가지고 좀 당황스럽기도 한데 일단 저는 거의 그 역학자로서 일단 기존 하는 그 데이터를 위주로 해석을 하다 보니까 그렇게 좀 디테일한 부분까지는 고려하지는 못한 게 사실이고요. 그래서 아무래도 좀 일반적인 그 신체 활동이 질병에 미치는 영향이냐 뭐 이런 것들 위주로 했기 때문에 그거에 대해서는 조금 더 포인트 드리고 그런 부분이 있는 것 같아요. 지금 교수님께서 뭐 쓰시는 좀 얘기 좀.
뉴로 엔도크라인 쪽으로는 해보진 않았는데요. 저희가 바이오마커 기반으로 남자랑 여자랑 운동을 하는 사람들과 안 하는 사람들 어떻게 차이가 있나 이런 것들을 좀 본 적이 있어요. 그러니까는 바이오마커라고 하는 건 뭐 되게 특별한 건 아니고 실제로 건강검진 하는 사람들한테서 하는 뭐 혈당치, 근육, 뭐 아니면 콜레스테롤, 아니면 비세럴 팻 이런 쪽의 그런 종류의 바이오마커 한 40개 정도가 그렇게 40개 정도가 있는데. 그게 남자랑 여자랑 운동을 하는 사람들에서 뭐가 좀 더 달라져가지고 나중에 메타볼릭 신드롬이랑 연결이 되나 이런 걸 봤을 때 남자랑 여자랑 공통적인 거는 콜레스테롤 쪽, 그러니까 지질과 관련된 바이오마커들은 줄어들어요. 똑같이. 그런데 남자들은 그 근육과 관련된 팩터들 그런 것들이 좀 더 좋아지더라고요. 거기에 비해서 여자들은 그쪽은 잘 안 나오고 네. 근육이 아니라 오히려 팻, 비세럴 팻이 좀 나빠지는 그런 쪽의 반응들이 보였습니다. 그런데 그게 물론 그 남자와 여자의 차이냐? 아니고, 말씀드렸다시피 남자, 여자는 운동하는 패턴이 완전 다르거든요. 그러니까 비고르스한 운동을 남자들이 훨씬 더 많이 해요. 그래서 그런 거의 차이지, 그런 부분들까지는 고르지를 못했어요. 왜냐면 숫자가 좀 적어서.
섹션의 특성이 역학이다. 이 질문을 드리기는 좀 어려웠지만, 저희가 이제 운동이라는 걸 한다면 항상 신경계가 움직여야 내분비가 훈련을 이루어서 운동에 액티비티 이루도록 만들어주는데 그 과정 동안에 훈련하는 부분에 분명히 젠더별 차이가 있지 않을까 혹시나 조사가 있겠습니다.
네, 감사합니다. 지금 시간이 한 40분까지 저희 시간이 주어져 있어서요. 한 가지 정도 질문 더 받으면 될 것 같습니다.
발표 일단 너무 두분 다 있었고요. 일단 두 분에게 다 질문이 있는데 먼저 정호 교수님께 그냥 흥미롭게 들었던 부분 프리스 메서더지 관련해서 말씀해주셨는데 일단 에피데미ology 데이터 중에 리스폰더랑 non 리스폰더에 대해서 어떤 데이터가 나와 있는 게 좀 있습니까? 그 예를 들면 실제로 역학 조사를 해봤을 때 몇 퍼센트 정도는 리스폰더가 있고 혹은 몇 퍼센트 정도 non 리스폰더가 되는지 그런 데이터가 있는지 여쭤보고 싶고 최근 교수님께는 그 비만 관련해서 연구하실 때 보통 대부분 이제 서양 연구에서는 다 BMI 30을 두고 하는데 국내에서는 25를 기준으로 하고 있는데 그게 정말 크게 영향을 데이터에 미치는지가 굉장히 궁금했습니다.
네, 제가 먼저 말씀드리면요. 일단 좋은 질문 감사드리고요. 일단 지금 말씀 주신 부분을 좀 해결할 수 있는 연구가 제가 마지막 주에 보여드렸던 그 Molecular Epidemiology Study라고 좀 생각이 들거든요. 그 연구는 비교적 좀 최근부터 시작이 됐어요. 거의 뭐 실제로 뭐 스터디가 되게 많지도 않고요. 그래서 아까 보여드렸던 게 제가 좀 몇 가지 예를 보여드렸는데 아직 데이터는 많지는 않지만 그 하버드에 있는 그 Yonsei Study랑 헬스 프로페셔널 화르 스터디에서도 한 5개 뭐 정도 내외로 있거든요. 그래서 대장암 환자를 대상으로 이제 그 서브타입을 좀 나눠서 봤더니 아까 보여드린 것처럼 그 P21이랑 P27이나 이런 것들을 그 익스프레션 된 사람들에게 있어서 조금 더 강한 그런 운동의 효과를 보이는 결과도 보여줬고요. 그리고 또 뭐 혹스라든지 또 IRS1이라든지 이런 시그널링들이 실제로 그 캔서와 관련되어 있는 그런 뭐 인슐린 그 시그널링이라든지 그 인플라메이션 그 리스폰스랑 워낙 밀접한 관계가 있는 것들이기 때문에 그걸 기준으로 나눠서 봤더니 실제로 한쪽 그 스테이터스가 있는 그룹에서 조금 더 운동 효과가 있더라라는 그런 결과를 보여주기는 했어요. 근데 일단 중요한 거는 이 Molecular Epidemiology Study 자체가 워낙 스터디 자체가 좀 작거든요. 어쩔 수 없이 그 서브타입을 다 가지고 있어야 되고 샘플 사이즈도 작고 그리고 또 셀렉션 바이어스가 있을 수도 있어요. 이미 뭐 죽은 사람도 있을 수도 있고 그런 문제들도 있고 아니면 뭐 메저먼 에러도 당연히 있을 수 있고 그 서브타입 그 메저하는 과정에서 등등 여러 가지 바이어스가 또 들어갈 수 있는 요소도 있고 서브타입이라는 것 자체가 워낙 여러 가지여서 멀티플 테스팅도 있다 문제가 될 수가 있어요. 어떤 게 하나 얻어서 걸린 걸 수도 있기 때문에 다시 그 리프로듀스 할 수 있는 게 굉장히 중요한 문제거든요. 그러니까 앞으로 더 많은 연구들이 나와서 그런 것들이 좀 더 리프로듀스 돼서 좀 컨펌할 수 있는 그런 연구들이 나오게 된다면 앞으로 좀 의미 있는 결과들이 나오지 않을까 일단 생각을 좀 하고 있습니다. 네, 감사합니다.
네, 오비시티 BMI 25가 적당하냐? 아니, 뭐 진짜 아닌지 잘 모르겠어요. 근데 사실 연구하는 사람 입장에서 그리고 저도 25까지는 아니고 전 23을 넘겠다가 왔다 갔다 하는데 아시다시피 아시안에서는 23 레벨을 쓴다 비만학회 뭐 이런 데서 그런 말씀들을 하시는데 연구를 하는 입장 혹은 이 페이퍼를 보면 23도 그렇게 높은 것 같지는 않고 25? 뭐 비슷합니다. 그런데 일단 데이터를 보시면 30 이상은 목표가 안 됩니다. 지금 전체에서. 그래서 분석이 좀 어려웠고요. 또 한 가지는 이제 이건 아니고 일반학 연구를 하는데 비만 연구를 하는데 저희가 그 레벨을 25 넘냐 안 넘냐를 봤더니 페이퍼에서 왜 아시아인들이 25를 써? 23 써야 되는 거 아니야? 뭐 이런 리뷰를 받긴 했었습니다. 그래서 일단 가장 큰 이유는 데이터의 통계상의 파워 때문이었습니다. 그렇지만 그래도 25라는 것 자체도 오버웨이트한 그런 기준이라고 생각해서 그렇게 결과를 했습니다.
네, 감사합니다. 제가 추가로 하나 코멘트할 게 있는데요. 처음에 이제 첫 번째 강의에 이제 Q&A 세션에서 전해선 교수님이 가스트릭 캔서, GI 캔서가 어떻게 스타일리티가 더 많이 이렇게 개선시키느냐라는 점에서 한 가지 조금 제언을 하면 제 생각에는 이제 그 신체 활동을 많이 하게 되면 콜론 트랜스 타임이 좀 줄어들게 됩니다. 저희가 실험 연구를 여러 차례 했었는데요. 그래서 이제 우리가 식이섬유를 섭취하면 이제 볼륨이 높아져서 많이 이제 배출이 잘 되잖아요. 잘 돼서. 그래서 여러분들도 아마 경험상 신체 활동을 많이 하실 때 배출 잘 된다는 걸 경험적으로 아실 텐데 그런 부분들이 좀 관여할 수 있지 않을까 그렇게 추측을 해봅니다. 네, 지금 시간이 다 돼서 이것으로 Q&A 세션, 디스커션 시간.
Can I ask a question? Sorry. So thank you for the excellent presentations. I've just got one question. So in Ed's talk, he talked a lot that essentially, I'm paraphrasing, but exercise in cancer is through adiposity.
and maybe then through insulin, good transit time, inflammation. Nobody's mentioned immune function this morning, and I would argue that most of the evidence we have in exercise and cancer is through immune modulation. So, could you comment about that?
I absolutely agree with you. Immune function is absolutely important mechanism we need to think about. I think Ed just missed that. And I read his actually comment on physical activity and cancer risk, and he actually mentioned immune function, but he maybe forgot to mention it. But as you know, the inflammation and insulin pathway is more, I think it's more of, we have more evidence so far, I think. The immune function, we do, but yeah, it's absolutely important. I mean, we need to, I think, take into account that too, yeah.
So I think most of the evidence we have on immune function, on insulin metabolic, is through blood, measuring glucose, insulin, IGF-1, insulin like growth factor 1, and showing that exercise decreases those factors. But the mechanistic evidence from preclinical studies, mouse studies, the strongest evidence is for immune function. So I think I think traditional thinking has been metabolism, but I think the mechanistic evidence is strongest for immune function, at least in breast cancer, it seems.
Yeah, but at the same time, this is active physiology session. And for immune function, there's so many markers that we try to measure, and then we always inconsistent. Some increase, some decrease, and make it almost sometimes impossible for us to interpret. So I think that's why the epidemiological studies, use of immune function as one of the factors is always challenging. That's my opinion.
Can I ask one? One more. I think the relationship between what Ed said, physical activity, cancer, visceral fat, BMI. I think what's important to remember is BMI is not a behavior. BMI is an outcome that is in large part determined by two things: the amount of exercise you do and your diet. So it's not surprising that increased risk with higher BMI, you see the reverse of that with exercise, because in BMI, because exercise is part of the equation that you get to BMI. So I think a lot of people think BMI is a behavior. It isn't. Diet is the behavior, exercise is the other behavior that leads to determines your BMI. But the combination of diet and exercise also determines things like blood pressure, many other physiological factors. So would you see the same thing if you just substitute BMI out and put in blood pressure? So I think it's a little bit to say that's the causal pathway. I'm not sure.
I think that's a challenge we have in epidemiological studies. Like BMI could be of course, it could be a confounder, and also it could be a mediator. And also it's very hard to distinguish. Like you said, we can put maybe blood pressure as a mediator. But I think maybe the effect would be, I don't know, we need to evaluate that, but it's really difficult to do in epi studies.
In epi studies, I've done it too, so I'm guilty. People use BMI to look, but it's not really BMI, it's diet. And we use BMI as a surrogate of diet, which is not the same.
But we do our best to adjust for like diet quality and total intake and so on. So I need to think more. Thank you.
It was more of
It was hot discussion. We have no time. We're running out of time, so we finish this session and coffee break and talk about together. Yes. Thank you.
The session title is Multidisciplinary Efforts to Treat Cancer Survivors. We have 3 speakers ready, and I am one of the chair, Haydong Lee, from Department of Physical Education, and my major is biomechanics. So I'm learning a lot of things from this session also. And I have a co-chair, Dr. Min-Sung Oh.
I'm a research professor in the Department of Sports Industry Studies here at Yonsei University. So I would like to introduce the first speaker, Dr. Jin-Hwa Che. Dr. Jin-Hwa Che is an associate professor at the Department of Radiation Oncology at Chunwon University College of Medicine. So she is an expertise in radiation oncology of breast cancer and head and neck cancer, GI cancer, and so on. So she will give a presentation regarding the sarcopenia experience and research in oncology patients. Please give a talk, Dr. Jin-Hwa Che.
Hello, my name is Jin-Hwa Choi, a radiation oncologist from the Chunwon University Hospital. I would like to thank the Professor John for giving me this opportunity to present about my research. Today, my presentation topic is sarcopenia experience and research in oncology patients. Actually, I think my topic does not fit session title, but I ask for your understanding. Following is the flow of my content. The introduction. Cancer cachexia is a multifactorial syndrome defined by an ongoing loss of skeletal muscle mass. Patients with cancer are high risk for sarcopenia because both of disease and its treatment, surgery, radiotherapy, and chemotherapy. Cancer patients have a higher incidence of lower skeletal muscle than healthy patients, with an incidence rate from 15 to 40%. Skeletal muscle mass depletion is associated with a higher incidence of chemotherapy toxicity and poor prognosis in cancer patients. Several studies reported that the treatment toxicity is higher in patients with sarcopenia. In breast cancer, the toxicity was 20% in non-sarcopenia patients, but 50% in sarcopenia patients. And in colon cancer, patients with decreased muscle mass had increased risk of grade 3/4 toxicity after chemotherapy. This high toxicity of treatment in patients with sarcopenia can interfere with cancer treatment. As a result, sarcopenia has shorter time to progression and poor overall survival. We also studied the effect of sarcopenia on prognosis in elderly rectal cancer patients who underwent chemoradiotherapy and surgery. In rectal cancer, preoperative chemoradiotherapy is performed as a standard treatment. Because preoperative CCRT has lower local recurrence and treatment complication than postoperative CCRT. Actually, when we first conducted this study, we planned to analyze whether preoperative CCRT is more beneficial than postoperative CCRT in elderly patients. Sarcopenia as a prognostic factor was the secondary endpoint. In this study, sarcopenia was compounded based on SMI using pre-treatment diagnosticity. In our study, preoperative CCRT did not have survival or toxicity benefit than postoperative CCRT, but sarcopenia was found to be related to poor prognosis. In rectal cancer, the elderly patients with sarcopenia have poor overall survival and disease-free survival. We were curious about the change in muscle mass during cancer treatment. We wondered whether the treatment caused sarcopenia or change in muscle mass during treatment affect treatment outcome, especially in patients receiving palliative therapy. In fact, since I am a radiation oncologist, I want to conduct research on patients receiving RT, but patients receiving palliative RT were very heterogeneous, and we not suitable for the study. So we conducted research on patients receiving palliative chemotherapy. Let's begin with chemotherapy-induced sarcopenia. Chemotherapy may also reduce muscle mass. This picture shows skeletal muscle loss post-chemotherapy. We investigated skeletal muscle mass change during palliative chemotherapy for advanced gastric cancer, and it's associated with the treatment outcomes. We retrospectively reviewed 111 patients at the third lumbar vertebral level using CT scan at baseline and at the time of disease progression. Key endpoints were skeletal muscle mass change, body mass index, response, and survival. Median pre-chemotherapy to post-chemotherapy SMI, BMI, and body weight decreased were 11.3%, 3.2%, and 3.5% respectively. SMI, BMI, and body weight decreased significantly during chemotherapy. The median overall survival was 10 to 12 months in patients with gastric cancer who received first-line palliative chemotherapy. The decreased SMI group had a significantly shorter overall survival compared to the maintained SMI group. The patient with sarcopenia also had a significantly shorter overall survival than patients without sarcopenia. The median SMI decreased for patients with objective response, stable disease, and disease progression were -4, -4, and -4.5 respectively. Response to chemotherapy was not associated with SMI decrease. Anyway, skeletal muscle loss during chemotherapy, and it is associated with poor prognosis. So we concerned about maintained muscle loss during chemotherapy. We considered exercise for patients treated with palliative chemotherapy. Research about studies of exercise for patients with cancer. Studies on exercise therapy has been searched for in many types of cancer and or setting in cancer. Cancer survivor, neoadjuvant, and metastatic setting. Exercise program were various, and outcomes are also various. There is no standard exercise program, so we thought it is important to describe the exercise program in our study where in the protocol. The exercise intervention conducted in our study was composed by rehabilitation medicine professor. Exercise is one of the treatments to improve sarcopenia. However, there is currently insufficient evidence on whether exercise can improve sarcopenia in patients with advanced cancer during chemotherapy. Especially, there was no report of whether exercise is possible during palliative treatment in cancer patients. This study examined the feasibility of exercise in advanced gastrointestinal cancer patients treated with palliative chemotherapy. This study prospected pilot study for feasibility and recently published in Sarcopenia, supportive care in cancer. Patients included advanced GI cancer, or patients were required to perform exercise for 6 weeks. If no problem, exercise can be extended to 12 weeks. The primary endpoint were compliance and attrition rate, and the secondary endpoint were change of body composition, physical function, and QOL. We assessed the following variable at baseline, 6 and 12 weeks. QOL, hand grip strength, gait speed, APCT, and body. The exercise consists of 3 levels of intensities: lower, moderate, and high. Before starting palliative chemotherapy, patients consulted the rehabilitation medicine to receive education on exercise. Patients were recommended to start with the lower intensity and to increase their intensity if tolerable. They could increase their intensity depending on their ability. Low intensity exercise is 9 to 10 points of RPE. According to the original org scale, it is about 30% on heart rate result. Exercise consists of a total 30 to 40 minutes. The exercise performed as follows. First, warm-up is done for 5 minutes, including stretching and breathing training. And then main exercise for more than 30 minutes, treadmill at lower speed for aerobic training, and ergometer with some resistance for resistance training. Finally, cool down for 5 minutes to finish with stretching and right pressing. Moderate intensity exercise is 11 to 12 RPE. This is able to maintain a conversation without getting out of breath while running. Warm-up and then main exercise for 30 minutes consists of treadmill at low moderate speed for aerobic training and using Seraband for resistance training. Finally, cool down. High intensity exercise is 40 to 50 RPE. It is a pace that requires some pushing and effort to maintain. Still able to hold a conversation. Main exercise consists of treadmill and moderate high speed ergometer using dumbbell or isotonic resistant band. One of the important things in rehabilitation medicine, consultation is to let patients know how much RPE they perform exercise. Then patient can describe the intensity of their exercise in their exercise log diary. When a patient performed more than 50% of the suggested exercise time at any intensity, it was defined that the patient have performed one exercise intervention. Compliance of more than 50% of exercise intervention was considered acceptable. Between November 2020 and August 2021, 30 patients were enrolled. 3 patients withdrew the consent due to deterioration of their condition before exercise. 3 patients had early progression before 6 weeks, and chemotherapy was stopped. 3 patients could not complete their exercise due to their worsening condition. Finally, the attrition rate was 30%. This slide showed the baseline characteristics. The median age was 60 and 57% were male. Colorectal cancer patients were the most common, followed by pancreatic and palliative biliary tract cancer. Most of patients were treated with first-line chemotherapy. One of the total 30 patients, 19 patients performed more than 50% of exercise intervention during the 6 weeks. exercise compliance rate was 63.3%. The number of patients who exercised in the second cycle of chemotherapy was similar to that in the first cycle. However, during the third cycle, fewer patients performed their exercise compared to cycle 1 and 2. The median exercise time for cycle 1, 2, 3 was as follows. Although a small number of patients performed exercise, those who exercised in the third cycle had a significantly increased in mean exercise time. This slide shows characteristics of exercise. Blue color indicates aerobic exercise and red color resistant exercise. More patients performed the aerobic exercise than the resistant exercise. However, resistant exercise was performed in 32% of all patients. From A to C, red color indicates moderate intensity exercise. Most of the patients performed moderate intensity exercise. From D to F, blue color indicates home or near home, and most of exercise placed was home or near home. The mean skeletal muscle index was decreased to 1.2. This was only significant. In the for compliance group, the mean SMI was more decreased and significant. However, in good compliance group, the SMI decrease was not significant. In the good compliance group, also physical function was maintained for 6 weeks. The QOL was maintained for 6 weeks. The insomnia was shown a significant better score. In advanced GI cancer patients, during palliative chemotherapy, exercise intervention had a good compliance. Most patients may performed aerobic and moderate intensive exercise. However, some patients could be performed resistant and high intensity exercise. Most patients performed exercise at home or near their home. The QOL was maintained. In the good compliance group, muscle mass and physical function were maintained for 6 weeks. These results can be used in training further advanced trial. While performing exercise intervention training study, we receive a lot of questions about diet from patients. We wonder if adding nutritional intervention to exercise would have a better result in preventing muscle mass loss during palliative treatment. So we planned a study on exercise and nutrition intervention. The following is about exercise and nutrition in cancer patients. This is our study schema. Key inclusion criteria are older patients with advanced cancer and plan to start palliative chemotherapy. Patients with cognitive decline and requiring limited exercise was excluded. If patients agree to participate in this study, they will receive exercise and nutrition intervention. And if they do not agree, they will receive usual care. Although this study is not a randomized clinical trial, it is intended to compare with the outcomes with patients in the usual care group in the future. Key endpoints are the same as in previous exercise intervention studies. In this study, exercise intervention was the same as in the previous study. As a result of researching on nutrition and intervention, we decided to implement the nutritional intervention conducted in reference paper. We invited Professor Bang Young-suk, Department of Food and Nutrition, Hanyang University, as a research for nutritional intervention. This study was reported by Professor Bang and to evaluate a dose-dependent approach of protein supplement on muscle mass and primarily in prior elderly group. In this study, provided customized protein dosage 24-hour nutrition diet report. Research subjects can submit a powder based on their usual intake or protein estimated by 24-hour report during screening. They receive individual adjusted amount of protein powder to prepare 1.2 or 1.5 gram per kg per day. We assess the following variable. These variables are same as in previous study. Thank you for your attention.
Thanks, Dr. J. We have a Q&A session at the end of the two more speakers. So I'd like to introduce second speaker, Dr. Ji Young Lim from Research Institute for Future Medicine, Samsung Medical Center. Her research interested in digital technology in physical education and rehabilitation, and she will give a talk with the title Digital Health to Support Exercise and Physical Rehabilitation for Cancer Survivors. Please give her a round of applause.
Thank you for the introduction. I'm delighted to be here. Thank you for the invitation. This opportunity, I think it will be a valuable time to run a new personality. Today's my presentation topic is digital health to support the exercise and physical rehabilitation for cancer survivors. This is a disclosure. Before the presentation, I did talk about my personal story. When I started my doctor's course, I joined Professor Ji Hwang's research team in the Department of Rehabilitation Medicine at Samsung Medical Center. And it was my first time to learn about cancer rehabilitation and digital health. In fact, I was unfamiliar with this research when I participated in it, but now I'm exploring in this field in depth. Through this time, I'd like to pass our research team's experience along to you well. As you already know, but I will briefly look at the definition of cancer survivors. Cancer survivors refer to all people who have survived since diagnosis. Furthermore, it has an expanded concept that includes their families and caregivers. As you can see, the treatment journey for those cancer survivors is very long. It can be divided into 4 major phases, and each phase is characterized by the fact that the different health problems and health management difficulties they experience are subdivided and last for a long time. Therefore, it is necessary to recognize that the healthcare needs of cancer survivors are very diverse and change dynamically depending on the period. The current survival rate in Korea show that 7 out of 10 people survive for more than 5 years. Cancer survival rate in Korea are steadily increasing through advances in cancer treatment technology and early screening. However, as we enter the aging society, the life expectancy of a cancer survivor is getting longer, and if functional morbidity is not properly cared for, there is a high possibility that they will live with the burden of healthcare due to specific disease for the rest of their lives. To solve this problem and the diverse healthcare needs of cancer survivor, a comprehensive and systematic approach is very important. Various efforts and changes appear to be necessary to provide long-term effective care for the increasing number of cancer survivors within limited resources. As WHO recently announced a 5-year strategy for digital health, it seems that the world is trying to overcome several health system challenges by utilizing digital health. In 22, WHO and FDA defined it as a comprehensive term that includes mHealth, e-health, big data, AI, wearable device, personalized medicine, etc. And as far as I know, there is no internationally agreed upon definition. When WHO published the materials related to digital health, it cited this definition. I found this explanation very appropriate. Digital health is the systematic application of information and communication technologies, computer science, and data to support informed decision making by individuals, the health workforce, and health system to strengthen resilience to disease and improve health and wellness. The background to this rapidly emerging digital health is the pandemic. Receiving treatment safely has become important, and many people use smartphones to obtain information and manage their health through apps, wearable device, and digital media. It means that there is more interest in healthcare than provided. It seems like various types of digital health tools have now become part of our daily lives. Among them, I will explain focusing on health. Digital health apps and research have been steadily increasing. Interestingly, we can see that proportion of digital disease-specific apps is gradually increasing. There are about 2,500 apps, and about 6% of them were developed for cancer. They provide continuous monitoring or display health data clearly. As of 2020, numerous studies are being published on the effect of digital health. As a result, evaluate maturity at IQVI in the case of cancer candidate for adoption was found. Because the types and journeys of cancer are very diverse, it is believed that it will take more time to reach the guidelines level. On the other hand, in the case of exercise, just like cancer, it was candidate for adoption in 2017. We are able to see a significant change in candidate for inclusion in clinical guidelines in just 3 years. It is assumed that great efforts have been made to verify the effectiveness of digital health-based exercise intervention. For cancer survivors, exercise already considered a key treatment in the cancer care journey based on numerous evidence. In particular, resistance exercise and aerobic exercise are strongly recommended during active treatment. This will soon become routine treatment, and in order to realize this, efforts are needed throughout the healthcare system, including receiving sufficient training and developing clinical-based programs that take patient needs into consideration. Ultimately, it will be our task for patients to overcome barriers to participation in exercise, to live health, maintain it, and ensure that all patients have access to exercise as part of cancer treatment. In this context, it seems like that digital health-based exercise intervention can be meaningful for cancer survivors undergoing treatment. The result of the umbrella review showed that these interventions are effective and feasible. I think everyone is well aware of the benefit of exercise and meditation. The potential benefit of digital health can include access to various information without time and space constraints, ensuring continuity of health care and increasing the efficiency of cancer rehabilitation and exercise-related healthcare service. Previous research has shown that cancer survivors have positive attitude toward exercise and are interested in willing to participate in physical activity, it can be seen that they wanted to receive guidance and support for those exercise from healthcare professionals. Additionally, it is important to note that preferences for physical activity vary greatly. This shows that cancer survivors need reliable information resources and psychosocial support regarding participation in physical activity, and the importance of personalized physical activity programs was found. Digital health can be used as a tool to encourage physical activity participation and deliver customized exercise and physical rehabilitation programs. I will explain the visual exercise and rehabilitation intervention conducted by our research team. Breast surgeon, rehabilitation medicine specialist, physical therapist, and exercise expert participated to develop an evidence-based rehabilitation exercise and physical activity program after breast cancer surgery. In addition, it provided health information and enabled self-management of diet, sleep and weight, and etc. The goal was to restore physical function and maintain physical activity after surgery. For this purpose, an algorithm was created based on the user's information, including the period from the surgery date, breast reconstruction, and age. Selective exercise provided the shorter rehabilitation exercise in stages, taking into account whether breast reconstruction was performed and the recovery of range of motion over time. In the case of aerobic exercise, when they wear the smart band and starting exercise, real-time feedback is provided on achieving their target heart rate, and they can check their exercise performance time. All exercise start at low intensity, and after exercise, the exercise intensity is automatically adjusted based on the user's RPE. If a patient begins chemotherapy, we help them practice physical activity by lowering the intensity of exercise, taking into account the impact of treatment. Also, it was developed to allow web-based monitoring of each patient's self-management practices. This mobile app for self-management support was provided to patients immediately after breast cancer surgery for 1 year, and its feasibility and usability are evaluated. Looking at the digital health intervention delivery process, upon registering for the study, participants sign up for the mobile app, and education was provided on mobile app functions, how to use the smartband, and the importance and content of exercise. Once the intervention began, compliance monitored, and if cancer survivors do not use the mobile app for more than 1 month, the reason was identified and they are encouraged to use it. If there are any other problems, action was taken. On the day the patient visit the hospital for follow-up, the cancer rehabilitation specialist provides general feedback on the use of the application. Let's look at the result. Treatment usually began 34 days after surgery. For the first month, they exercise every day, regardless of the type of exercise, then gradually decreases to 5, 3, and 2 times per week. As a result of the number of steps, the number decreased to about 7,000 steps per day after treatment began. Approximately 6 months after the end of chemotherapy, the number of the steps increased and reached almost 10,000 steps. Breast cancer survivors who complete the study responded that digital health services are useful for post-operative health management. Also, I could see that their was a lot of interrupted exercise and diet management function during treatment. When we check the feedback on exercise management, breast cancer survivors request diversity in exercise content, consideration of individual health conditions, and improved usability of smartphones and mobile apps. Despite these usability issues, they would like to recommend it to other patients because it is helpful for overall disease and health management and can be conveniently used anytime, anywhere. Previously, as we provide exercise based on mobile health, there was some limitation. I couldn't tell if they actually performed the exercise well. In particular, because a settled exercise program was provided according to an algorithm, there are limitation in prescribing exercise tailored to the individual. Therefore, we applied augmented reality-based shoulder rehabilitation exercise for 8 weeks after surgery using a 3D camera and motion analysis technology. Augmented reality allow patients to accurately perform movements by following virtual movement target points when exercising at home and provide real-time feedback. When the digital healthcare system is delivered to the home and the patient performs the prescribed exercise, performance and accuracy are monitored via the web, and the exercise level is adjusted using the exercise prescription system. Although patients initially had difficulty and errors in using the system, they are willing to participate in digital exercise rehabilitation again in the future if necessary. Returning to enhance, our researchers applied a protocol similar to breast cancer survivors to colorectal cancer patients immediately after surgery for 1 year. For colorectal cancer survivor, we developed a rehabilitation exercise program to restore muscle strength and a pelvic floor muscle training program. We excluded workout that include increased abdominal pressure in the early stages. If survivors are undergoing chemotherapy, exercise focused on full body stretching and the overall exercise intensity is lowered. Immediately after stoma reversal surgery, the intensity of aerobic exercise is lowered and gradually increased. Next, digital health intervention was applied to stomach cancer patients for 1 year after surgery. With colorectal cancer, exercise that increases abdominal pressure is avoided in the early stages, starting at low intensity, gradually increasing exercise intensity and maintaining low intensity during chemotherapy. Until now, our emphasis was placed on patient safe because the spectrum of symptoms during treatment is diverse. And then we provided cancer-specific treatment journey, general information, and live-load database automatic exercise prescription. In order to provide safe and effective exercise intervention, especially in unsupervised settings, specific guidelines for cancer-specific doses during treatments are needed. So in the next step, we are planning to make the physical performance-based exercise prescription algorithm with the cancer rehabilitation and exercise expert. It will be stepping stone to providing patient-centered, more personalized, and pragmatic exercise. Thank you for your attention.
Thank you very much for the great presentation from Dr. Jiyoung Lim. So we'll move on to the last speaker of the session. So the last speaker is Dr. Sung Kim from the National Cancer Survivor Center at the National Cancer Control Institute. So his research focus includes digital health communication, and health intervention message design. And his presentation is titled Dr. Meta, Experience of the Multi-Domain Metaverse Cancer Care Digital Platform. So please welcome Dr. Kim.
Thank you for the introduction. So hi, my name is Seong Kim, and I'm at the National Cancer Center Korea. And it's my pleasure to introduce our medical metaverse research project and then our platform Dr. Meta in the Yonsei Exercise Oncology Symposium. So today I will gonna present the findings of the usability test of our platform based on the National Cancer Center data collected in 2023. And this still is ongoing project, but still I'll start the talk. So as you may already know, cancer is a major public health concern worldwide. So active cancer education and care are crucial to cure cancer successfully. However, there's a huge hurdles to provide cancer education and care physically. For example, there can be the outbreak of the infectious disease such as COVID-19, and there's also disparity of medical access. Disparity of the access of the medical resources and infrastructures among every different regions. So therefore, the interest in the metaverse as a means of making users engage in the cancer education and care beyond the physical constraints is gradually increasing. And then the previous literatures already revealed and still ongoing, the metaverse influence in the context of cancer. And for health professionals, metaverse can be used to develop and use the effective surgical and educational tools. And for patients, this metaverse can be used to increase patient satisfaction with oncology care and improve therapy training knowledge and reduce cancer-related symptoms. And it can be indirectly affect the psychological symptoms as well. And so the metaverse can be used in the different cancer-related groups remotely and help both cancer education and care. And integrated metaverse services advantages for meeting the needs of various groups of users. However, the many past studies are the review papers or the single platform focuses or small scale research. And it is challenging to find the multi-purpose medical metaverse that is used in the actual field right now and substantially complements the current cancer care. And therefore, we developed the multi-domain metaverse cancer care digital platform, which called Dr. Meta. And it was initially developed in 2021, and it is continuously operating by adding new sub-platforms and content. So right now, technically we can say that we have currently 5 or 6 platforms, actually, because the metaverse stomach care is 2 different versions. But right now we're currently running these 6 sub-platforms. And now we are developing in development. The one is metaverse abdominal breathing. So we are designed to create this sub-platform to educate and then make them patient practice this abdominal breathing. And another one, a sub-platform we are currently developing is a metaverse pediatrics. So this is aimed to provide the physical and social support to children or adolescents who suffer from the cancer. So these 2 platforms, we are aiming to finish the development by end of this year or early next year. So current sub-platform, the first one is Metaverse Multidisciplinary Conference. So as you may know in the title, this sub-platform we created for supporting this multidisciplinary conference. So health professionals from the various medical fields and regions can remotely cooperate in real time by accessing the virtual space as avatars and using the 3D medical objects and the audiovisual data. With regard to this sub-platform, actually today, so National Cancer Center and then all different, the 12 regional cancer centers in Korea, it's about like 10 minutes later, they want to actually started this multidisciplinary conference. The topic is ovarian cancer, and yeah, it's about to run this sub-platform actually. So after this symposium, I'm gonna go back and then see the data. I'm gonna just evaluate if it works well or not. Oh yeah, sorry. So in this platform, the picture doesn't show every space, but we have 4 big screens, and in these screens, the users can upload like a normal 2D files, Word file, presentation file, PDF file, and also they can upload these icon data, X-rays or CTs data as well, and then also user can upload this 3D object. If they already saved in the database, they can upload this 3D medical object. Organ is a popular one, and we can also have a separate medical device which can assemble and disassemble and teaching or showing to the other avatar users. The second sub-platform is a Metaverse Education Center. So health professionals from the other regions and then other medical institutions can access the virtual space as avatar to gain theoretical education and get interactive medical training. So we have 2 large screen or same function, similar to the multidisciplinary conference platform. They can also, users can also upload the 2D and both 3D object in this virtual space or 2D files in the screen, so multiple users can see the educational matters at the same time. And then also the user can run around or sit in the chair, so they can feel all the group of members are having the same training at the same time. So it's kind of another level of the experience. And for concerning this sub-platform, actually last year, our department and then also the cancer early detection department in the National Cancer Center Korea, we collaborated and then using this platform and embedded the VR content, which the topic is memory position training. So we distribute this content and platform to every single regional cancer center in Korea. So and then we train the radiologists, the technologists who's belonging to that regional cancer center, and then it was successful training. The third one is metaverse camping. So patients and their family members can hang out with their relatives or their friends who live far in the virtual space, and they experience psychological comfort and psychological comfort and social support. So every avatars can run right now, but we are intending to developing the running functions. But basically we are walking. We have walking function, and then they can navigate around this camping site, and then they can also play small mini games such as these domino games, or they can watch the fireworks, or they can they can make a barbecue grills. And then we are also planning to develop a new mini game and embed it in this platform next year. Right now I'm considering fishing, but I don't know. We have to discuss. I discussed with my other team members. Fourth is that metaverse stomach care. As I told you, there are 2 different versions for health professional, and then another one is for patient. The users can access one of 2 versions of scenario-based virtual rooms, depending on their purpose, and learn theories and knowledge of stomach care or practice wearing the colostomy bags. So left picture shows the for health professionals version, and the right side is the for patient version. So for patient version, this avatar, but this first person point of view, they can virtually interact with this colostomy bag and then another tools, instrument, and then they can virtually practice by themselves. And fifth one is a virtual healing sphere. So users can watch diverse 360-degree videos and then to enhance the psychological well-being. So we have multiple categories of these videos: the travels category, performance category, and then exhibition category. The last year's data, when I ranked the categories, the travel category was the populist one because we assuming that the many patients want to go abroad or go to travel, but they couldn't because of their healthy condition. So this virtual content helped them to satisfy their needs of being travel and then getting the positive emotions. And this platform we are just constantly managing, and then so every patient who want to wear this device and then watching this content, they can register in our program list, and then they can watch this video when they want it. So they can visit our site, and then they're watching videos. We are running this software service like this. Okay, so this is a brief introduction of our platform. So I'm gonna next chapter I'm gonna publish this small but usually test ID. So this study aimed to examine user experience of Dr. Mehta in the 2023. So as I said, so this platform and the content is already being distributed in every different regional center, cancer center in Korea. And total 13, including the National Cancer Center. So 13 institutions are participating in this study. So we are using the multi-center cross-sectional survey design. So although participant age is 19 years and above were recruited from each cancer center. So yeah, this is a picture of the person who's using our platform. Okay, for the demographic information, before going on this one, I want to say this is only for the National Cancer Center data because I said it's still ongoing data, and then we are aiming to finish collection of this year's data in the end of December. So you can just think this is just currently ongoing data, and then only for the National Cancer Center patient and then health professionals data. So total 136 participants actually respond to our evaluation sheet. So you can see this participant number and the frequencies. You can see the health professional, doctor, and patient, and then other mentioned steps of educators usually used in our platform. Usually result, we calculated the number of participants who actually respond, provide positive opinion toward our platform. So we evaluate in each item with a 4-point scale. So 1 is strong disagree, 2, 4 strongly agree. And then we just calculated separately, but combine the agree and strongly agree participant and then added the number and then calculate the frequency scale. So so we focus on the satisfactions and the interactivities and the interest in the immersions or ease of use and the perceived usefulness or excitedness and then also trust. And the final outcome will be the continuous use of the intention. But this is still usually test level. We couldn't move it to the actual effect test yet, but I think this is a starting point of moving towards the next level of the analysis. For the finding, you can see was happy for me and our team. So most of users, like more than half of users who responded is was satisfied, and then they can also feel interest about this platform and they immersed as well. And then they want to continue using this platform in the futures. So this study's findings show the potential of Dr. Mehta's for successful cancer control. So next thing we're thinking about is now how to design the study which really actually test about the effectiveness of this platform for the users. And we have 4, and then considering the sub-platform levels, actually we also ask feedback from the participant after the evaluation, and then when we list of the most popular opinions, then there was 2 majority of number participants actually give us feedback that they want more interactive content, more interactive diverse content, and the second one was a little bit difficult to wear the device because it's too heavy. So we are focusing the 2 points of that feedback and then try to improve the interactivity and easy to access. So for the interactivity, the next year we are thinking about considering creating the content, scenario-based content, and then really users can actually interact with the 3D object in the virtual room. So right now, as I told you, we already did the demographic positioning training content, but that was just watching the videos, like 360-degree videos. But we are thinking about creating the scenarios which the users can actually grasp or touching the medical device in the virtual rooms, so they can enhance the level of interactivities. And also for the ease of access, we already tried to replace this device with adding the new accessories can reduce the weight of the device. And also we are developing another version of the platform which is web-based, not the Oculus device-based, and also tablet. So in short, we are creating the tablet-based or web-based services as well. So we are expecting to launch it in the next year. And then, yeah, another software we are thinking right now is metaverse for exercise we have. So the previous study has been examined and still testing the effect of this metaverse technology to the exercise we have. And then that several studies reported that users have a positive effect on the cognitive functions, and also they can improve the heart rate, and then they saw the positive effect of the metaverse in the exercise context. So considering the reviews, we are also thinking about creating this platform focusing on the exercise, and then but our team is still thinking about the scenario which is best. But we are still digging and searching the appropriate scenarios. So I don't know when we'll be gonna be completely developed, but we're expecting to create this one with this exercise as well. So this is the end of my presentation. Thank you so much.
Thank you very much for the speakers for very interesting topics and researches. So now we're gonna bring the speakers to the podium, or should we just go and ask questions? So the symposium schedule is slightly behind, so we. The conference chair is telling me that just a 10-minute Q&A, but don't worry about the time. So you can skip the lunch. You guys didn't exercise too much during this conference, so maybe you can skip the lunch and move on to the next session. So please. Before we start the Q&A session, would you please give a big round of applause? So the floor is open for questions. So you have questions, and firstly tell who you are, where you're from, and the questions in English or Korean.
while you are up, 혹시 마이크가
크게 하겠습니다.
예, 더 크게 하셔야 될 것 같습니다. 예.
서울 이제 최지역이고요. 강의 잘 들었습니다. 그 디스턴스로 하시는 거나 메타버스나 둘 다 충분히 관심이 많은 분야일 것 같은데 디스턴스 어떤 앱을 쓰는 경우에는 그래도 데이터를 이제 환자들이 주는 거를 주로 위주로 한다면 메타버스 같은 경우에는 서로 그 안에서 모이고 서로 인터랙션하고 그런 것들을 주로 하면서 할 것 같거든요. 뭐 그런 것들이 굉장히 보게 될 것 같고. 그런데 결국에 환자들은 나를 봐주는 사람들한테 더 많이 얘기를 하고 싶은 부분이 있을 것 같아요. 근데 그런 쪽으로도 이게 가능할지, 왜냐면 임상하시는 분들이 거기까지 같이 가서 인터랙션이 가능할 정도의 시간이 될지 뭐 이런 부분들이 좀 있다는 디지털스랑 메타버스랑 그런 차이나 그런 갭들을 한번 정리해 주시면 좋겠습니다.
혹시 질문을 다시 한번 제가 한번 이해한번 하려면은 이제 헬스 프로페셔널들이 와서 이렇게 직접 인터랙션이 없는데 그 데이터를 잘 컬렉션 할 수 있냐는 질문을 말씀하신 거죠. 분명히 그 부분에서 이제 릴라이빌리티에 대한 그런 퀴즈가 올 수는 있을 것 같습니다. 그런데 저희도 그런 부분을 좀 우려를 해서 지금 현재도 이제 저희 인사 간호사분들이나 아니면 이제 교수님들 방에서 직접 그분들 참관 하에서 이제 쓸 수 있도록 하고 있고요. 그리고 물론 이게 기술적인 한계 때문에 이 디바이스를 써서 하는 단점 이런 부분이 분명히 있습니다. 근데 그것도 저희가 지금 태블릿 베이스나 이제 웹으로 가는 또 두 가지 버전을 또 같이 운영하려고 하는 얘기도 하거든요. 그렇게 해서 최대한 인터랙션을 직접 이제 환자분들이 신뢰하는 의료진들과 함께 경험할 수 있는 그 익스피리언스를 주기 위해서 여러 가지 방법을 논의하고 있고 이제 최근에는 저희가 사실은 물론 이제 그게 같은 기관 안에서는 가능할 텐데 멀리 있는 기관이 또 한계잖아요. 그것 때문에 저희도 고민을 많이 하다가 최근에 이제 기술이 활성이 돼서 이제 3D 베이스의 메타버스에서도 이제 줌처럼 그 아바타들끼리 좀 더 가까이 가면은 실시간으로 화면을 뜰 수 있는 기능이 이제 만들어졌어요. 근데 그거 사실 카페하고 최적화하는 게 문제가 있긴 한데 저희도 그거를 계속 좀 고민 중이고 어쨌든 사실 저희도 이제 현장에서 말씀 주신 것처럼 이제 특히 상담하시는 분들이 이제 환자랑 대면을 해야 되는데 대면을 못하면은 이게 의미가 있냐라는 의견을 많이 주셨어요. 그래서 그거를 해결하려다 보니까 그런 기능을 찾게 되고 이제 해외에서도 지금 여러 가지 어려움은 있지만 계속 그걸 치료하고 있는 걸로 알고 있습니다. 그래서 저희도 이제 내년부터 이제 실시간 줌처럼 이제 실시간 화면 중계를 저희 메타버스 플랫폼에 넣으려고 기입하고 있거든요. 그러면은 이제 좀 어쨌든 직접 대면보다는 한계는 있겠지만 어쨌든 실시간 얼굴을 봄으로써 그런 것들이 일정 부분 해소될 수 있을 걸로 기대가 되고 있고요. 그렇게 해서 좀 이게 아쉬운 부분을 보완하면서도 어쨌든 비대면 그리고 또 몰입감을 줄 수 있는 경험 측면에서는 장점은 없기 때문에 사실 그런 여러 가지 대책을 통해서 보완하는 게 맞지 않을까 싶어서 저희는 그렇게 지금 진행하고 있습니다.
교수님들 말고 혹시 학생들 분들 중에 학생분들한테 프라이어티를 드리겠습니다. 학생들 분들 질문 없으신가요? 네. 소리를 조금 더 크게 해주셔야 될 것 같습니다.
네, 연세대학교 간호대학 박사과 정세희 단식이라고 합니다. 사실 메타버스가 이제 되게 다양하게 쓰이고 있는데 그 메타버스에 대해 질문들을 죄송하고요. 그 메타버스 관련해서 사실 저는 이제 연구를 좀 진행하면서 가장 어려운 점 그리고 항상 고민되는 점이 이게 이 메타버스로 구현되어 있는 이 월드의 퀄리티가 아무래도 좀 낮잖아요. 그리고 근데 이게 문제는 이제 저희가 연구를 구성을 연구를 이제 하려고 하고서 업체를 만나서 좀 이렇게 세팅을 하는 과정에서 하다 보면 또 이미 새로운 기술이 나오고 새로운 기기가 나오고 더 퀄리티는 좋아지고 그러면 또 지금 시점에서 연구를 하려고 보면 너무 환자들이 경험하고 수 있는 메타버스 세계와 연구가 구현할 수 있는 메타버스의 갭이 확 커져버리고 이게 되게 한계점이라고 생각을 하고 좀 제한점이라고 생각을 하는데 그런 거에 좀 갭을 줄이려는 노력을 어떻게 하시는지 또 그런 소요되는 시간 그런 것에 대해서도 한번 좀 궁금합니다.
질문 감사합니다. 늘 저희도 고민하고 있는 부분이라서 좀 더 주시는 질문이 많이 와닿는데 진짜 기술은 급변합니다. 정말 많이 바뀌고 저희가 뭐 하나 만들어 놓으면은 갑자기 또 다른 차원의 그래픽이 구현이 되고 그런 부분에서 아쉬운 부분은 생기는데, 근데 모르겠으면 저희 팀만의 그런 경험인지 모르겠지만 사실 저희도 초반에는 이제 그런 그래픽의 향상이나 아니면은 기술을 최신 기술을 구현하려고 계속 좀 서치하고 뭐 해외 아티클도 찾아보고 그랬었는데, 그거보다는 더 중요한 게 그냥 사용의 편의성이 더 제 연구 효과에 큰 영향을 미치더라고요. 그래서 기술이 뭐 최신 기술 썼다 뭐 이런 거보다는, 그래서 저희도 초창기에는 그런 기술에 대한 그런 그 열망이 가득했지만 좀 그거는 좀 덜어놓은 상태고, 어떻게 보면은 어떻게 하면 제일 간단하면서도 제일 쉽게 사용자들이 쓸 수 있는 콘텐츠를 만들고 시나리오를 짤까 이런 부분을 좀 많이 해서, 사실 기술 부분에서는 조금 물론 뭐 큰 기술들 같은 건 저희 계속 트래킹하면서 이제 찾아가는 건 있지만, 사실은 사용성을 높이는데 좀 더 유저들이 쉽게 접근하고 쉽게 쉽게 그 경험하고 하는 부분을 더 신경 쓰는 추세라서 그런 저희 연구팀 마인드가 있어서 네, 그런 고민들이 조금 약해지고는 있는 것 같습니다. 근데 뭐 말씀 주신 거 충분히 공감하고, 또 그런 이유 때문에 저희가 웹 베이스로 오히려 그 최신 기술 오플러스 VR 안에 구현하는 것보다는 새로운 뭐 대체 장비를 통해서도 구현할 수 있는 그런 버전으로 계속 발전시키려고 하는 그런 방향성의 변화가 있었다고 말씀드릴 수 있겠습니다.
말씀 조금 그 의견을 드리자면, 저도 그 이제 모바일 헬스가 사실 너무나 경험이 많잖아요. 환자분들이 이제 왜 이건 안 되냐 할 정도로 저희도 스마트밴드를 이 회사가 자체적으로 개발을 해가지고 제공을 했더니 갤럭시 워치 왜 안 되냐, 나는 예쁜 시계 차고 싶다. 특히 유망한 생존자분들은 더 특히나 그렇거든요. 그래서 저희도 그 테크놀로지에 계속 집중을 하다 보니까 결국 다시 돌아와서 맨 처음 당연히 테크놀로지는 사용성이 굉장히 중요하고요. 왜냐하면 어떤 목표를 달성하는데 가장 효율적으로 효과적으로 도달할 수 있게 만들어줘야 되기 때문인데, 결국은 이게 이제 수용 가능성까지 가려면 결국 의미가 있고 나한테 유용해야 된다는 게 가장 중요하다고 생각이 들었거든요. 그래서 그걸 결국 다시 돌아보면 이분들의 니즈를 결국 파악하는 게 가장 근간이 되지 않았나 싶고, 저희도 돌이켜보니까 이제 너무 헬스케어 전문가 관점으로만 이 서비스를 자꾸 구성을 하다 보니까 그 사이에서도 또 갭이 벌어지는 것 같더라고요. 그래서 그 부분을 놓치지 않으셨으면 좋겠습니다.
다른 질문, 네. 다른 질문 보겠습니다. 소리가 좀 작으십니다. 크게 해주세요.
대사선 종양내과에서 정말 좋은 운동용도를 많이 하시는 것 같아서 너무 이렇게 감사한 마음을 가지고 있고요. 아까 마지막에 그 온고잉 뉴트리션까지 같이 가는 온고잉인데, 혹시 조금 데이터 맛을 저희한테 좀 공유해 줄 만한 게 있으신지, 그게 더 좋아하시는지.
제가 이제 마지막에 코멘트를
네, 제가 마지막에 사실 이 연구가 아직 진행되고 있다고 코멘트를 좀 드렸어야 됐는데 이제 시간을 보고 좀 당황해서 사실 클로징을 했었습니다. 그리고 사실 아직 저희가 이제 오히려 실험군 환자분들은 이렇게 하시려고 하시는 분들이 많으시는데 대조군 환자분들이 없었어요. 그래가지고 아직 대조군을 다 찾지 못해서 이제 끝내지를 못해서 사실 아직 분석을 하지 못했었습니다. 그래서 나중에 이제 뭐 분석 자료가 좀 더 나오면 나눌 수 있을 것 같습니다.
좋아지는 경향이
중간 분석은 명확하게 말씀드리면 안 했고요. 이렇게 네거티브 데이터가 나오지 않을까 걱정을 좀 하고 있습니다. 네.
혹시 다른 질문 더 있으신가요? 네.
네, 크게 얘기하겠습니다. 안녕하세요. 강의대학에서 왔고요. 이한규입니다. 세 분께 다 똑같은 질문 또는 뭐랄까 좀 당부, 부탁이 될 것 같은데 두 가지인데요. 첫 번째는 저희 간호대학에서 이제 연구를 했을 때는 암 환자나 다른 만성 질병에서 사이콜로직한 그 상태, 이 사람들의 우울이라든가 피로감이라든가 이런 것들이 특히 회복이나 생존율에 상당히 많은 차이가 있는 논문들이 이미 올해 나왔는데, 혹시 지금 연구하시는데 이미 말씀을 좀 하셨지만 조금 더 사이콜로지컬한 그 부분을 확장도를 더 많이 포함해서 연구를 진행을 하고 계시거나 아니면 안 하신다면 좀 더 넣어주셨으면 좋겠다는 점. 그리고 이제 두 번째는 그 디지털 헬스를 많이 지금 사용을 하고 좋은 효과를 보고 있는데 실제로 저도 한 6개월 정도 사용했다가 최근에 연구를 아주 시원하게 망친 적이 있어서 이게 많은 사람들이 비대면으로 해서 사용도가 유용성이 많아지긴 했지만 장기적으로 중재를 하다 보니 중간에 계속 누군가가 개입을 하고 못 살게 굴어야 되겠더라고요. 연락을 하고. 그래서 아직도 사람의 손이 필요한 아니면 중재의 중간중간에 누군가가 그 모티베이션을 줘야 되는 게 있더라고요. 그래서 그런 그 문제점들은 혹시 어떻게 해결을 하고 계시는지 질문을 드립니다.
제가 먼저 답을 드리면 저는 임상을 하는 사람이기 때문에 환자를 주기적으로 사실 만납니다. 그래서 사실 이런 연구를 하기에는 저희가 조금 더 유리한 면이 있는 것 같아요. 환자분은 주기적으로 오시고 연구에 대해서 진행이 제대로 되고 있는지 환자한테 확인을 할 수 있는 면들이 좀 있고 또 실제로 이제 연구를 같이 해주는 연구간호사 선생님들이 계속 조금 이제 뭐 연락을 좀 드리거나 하는 식으로 해서 사실은 저희도 이제 다음 연구에서는 웨어러블을 고민하고 있거든요. 이게 좀 환자는 나는 이만큼도 했어 하는데 실제로는 그렇지 않을 수도 있기 때문에 이 데이터를 지금 활용하려고 저희도 이제 여러 가지 좀 알아보고는 있는데요. 근데 어쨌든 그것도 중요하지만 이쪽도 절대 놓치면 안 되겠다. 환자한테 결국은 환자가 전화를 받거나 뭔가 이제 사람을 만났을 때 되면 훨씬 더 이제 환자가 어떤 동기부여를 받는 데는 도움이 되는 거라고 좀 생각이 듭니다. 그리고 첫 번째 질문에 대답을 좀 드리면 저희 기관에도 이제 디지털 암센터라는 게 있습니다. 그래서 연구가 이제 좀 진행을 하고 있는데 그 디지털 암센터 맨 처음 설립할 때 저희는 정신과에서 처음 설립을 했거든요. 그래서 사실 정신과 메인으로 시작을 했고 오히려 정신과 선생님들한테 저희가 들어가는 상태였기 때문에 그 말씀하시는 대로 뭐 우울이나 여러 가지 환자들이 겪고 있는 문제들은 충분히 고려를 하려고 하는데 사실 그게 이렇게 분석을 하거나 데이터를 하는 게 좀 쉽지는 않은 것 같습니다. 그래서 이제 연구에서 저희들이 충분히 활용하고 있습니다.
그 말씀해주신 것처럼 좀 심리적으로 확실히 좀 안 좋으신 분들을 몇 번 경험을 저도 해보니까 제가 이렇게 조금 찌르는 역할을 했거든요. 이제 연구를 하면서 1년을 가다 보니까 안 찌를 수가 없어요. 말씀해주신 것처럼. 근데 이제 연구들을 저도 이제 계속 보다 보니까 결국 행동 변화가 일어나는 데 있어서 이제 효과의 크기를 따져 보니까 저희가 만든 이런 오토매틱한 거는 사실 약간 효과가 그렇게 크지 않습니다. 말씀하신 대로 그냥 내버려둔 거기 때문에 누군가 이제 뭔가 조금 더 이렇게 해주지 않으면 금방 모티베이션이 떨어지고 좀 그런 것 같고요. 그래서 중간 효과가 이제 의료진이 좀 그렇게 개입을 한 게 아무래도 효과가 있었고 제가 그래서 유방암 생존자를 1년 끌었을 때 좀 그래도 리텐션 레이트가 좀 높았던 게 한 75%, 360일 동안 그 메디안 값이 몇 년인지 생각은 안 나지만 한 270일 정도는 접속을 한 기록이 있더라고요, 환자분들이. 그러니까 그만큼 제가 계속 저희가 되게 짧은 기간으로도 많이 환자분들 오게 했고 실제 외래에서도 보게 했기 때문에 그분에서 환자분들이 좀 더 이거를 단순히 앱만 보는 게 아니라 의료진과 커뮤니케이션 하는 이 전반의 서비스를 모두 유용하다고 느끼는 것 같긴 하거든요. 그래서 그것도 굉장히 어려운 부분이라고 느끼는데 아직은 좀 하이브리드여야 되지 않나 싶습니다. 아니면 그 안에 행동 변화 이론을 조금 더 잘 녹여서 접근을 해야 되지 않을까. 감사합니다.
정 교수님이 시작하시는 겁니다. I'd like to thank you, the speakers, once more, and I hope you enjoy the lunch and discussions, and we will meet again 13:29. Yeah. So 1 minute before the session starts. So enjoy your lunch. Thank you.
네, 저 점심 식사 안내해 드리도록 하겠습니다. 제일 중요한 광고니까 집중해 주시고요. 네, 먼저 연세인 구성원 분들께서는 잠깐 기다려 주시고 우리 참석해 주시는 분들을 대상으로 먼저 안내해 드릴 건데요. 저희가 백양놀이 지하 1층에 있는 더 라운지로 식사 장소를 예약해 놨습니다. 그래서 그쪽으로 가시면 되고요. 먼저 전용관 교수님에게 미리 연락을 받으신 분들은 교수님 따라서 같이 가시면, 네, 더 라운지에 같이 가시면 되고, 저희 드시고 싶은 메뉴를 드시고 나서 영수증을 주실 거예요. 그러면 그거를 저희 전수산나 선생님 손 한 번만 들어주시면, 저 선생님한테 영수증을 주시면 저희가 결제를 한 번에 하려고 하니까요. 그렇게 알고 계시고, 연세 구성원 분들께서는 남아서 저희가 드린 식권이 있습니다. 그거 가지고 한경관으로 가시면 될 것 같습니다. 네, 감사합니다. 환경과 티켓 받으셔야 되는 분들 이쪽으로 오세요.